Our first speaker today is Sharon Rose. So would you make your way up here, join me? Sharon, want the title, like it or not, has been sustaining herself on home parenteral nutrition longer than anyone else in the U.S. She'll be approaching her 50-year mark, right? When is that?
October.
In October. And for that, I offer her my most sincere congratulations. She makes it look so easy. She's so humble. We know it's not easy to get there. She was navigating this journey before anyone else and working through a few kinks along the way. Yeah. So it's a simple can-do attitude with a strong will to allow this therapy to support life, but not run life.
Amen.
Amen. That's it. That's all I have. All right. It's all yours.
This is not the first time that I've spoken about the beginning of TPN. And for those that have heard me before, I ask your indulgence because I think it's important for consumers to know how very far we've come in a relatively short time. And this, hopefully, will give hope for the future and be a positive thing to think about. Back in 1968, I had just graduated from nursing. I had my first apartment, my first job. Things were wonderful. And then I developed abdominal pain. And like any good little nurse, I ignored it. Until one day the pain came and didn't go away. To make a long story short, I had blood clots that blocked the flow of blood to my small bowel. My small bowel became gangrenous, and then it ruptured, and I ended up having most of it surgically removed. I was young, I was healthy, so that I recovered from this surgery quite rapidly and was home in nothing flat. And the only instructions I was given on discharge is eat a bland diet. So I ate a peanut butter sandwich, which I loved. It didn't love me. I became, horribly ill, nausea, vomiting, steatorrhea, and after I completely purged everything out of my body, I'd feel good again, and then I'd probably usually eat another peanut butter sandwich, and the cycle kept going on. And needless to say, I steadily lost weight, and eventually I ended up back in the hospital. Now, this wasn't a small little country hospital. This was a good-sized city hospital, but they didn't know what to do with me. They gave me IVs, the usual sugar, water, and electrolytes, and they gave me the occasional bag of plasma, but, that was a drop in the bucket. It wasn't enough, and they just didn't know what to do, and I went steadily downhill. Eventually, one of the doctors there told me there was a doctor at the university center who had some expertise in nutrition. They had talked to him, and he agreed to take over my care. So I moved to the university center. The first thing he did was absorption studies to see how much I actually could absorb. It wasn't much. And then he sat on my bed and he talked to me about this new theory, this new therapy called hyperalimentation. From the very beginning, by the way, that's what TPN was originally called. From the very beginning, he told me he'd never done it to anybody, but he'd read about it, and that there was a doctor in Texas who had successfully treated several patients on this therapy, and he felt like that's what I needed. I agreed. So then became the process. He, of course, explained that it had to be rapidly diluted in a nice large vein, so I got my first central line. In those days, they were a little different than what you probably all know. It was placed at the bedside. They used a large bore needle and got into the subclavian vein, and through the center of that needle, they threaded a thin, hard little plastic catheter. After the catheter was in the vein, they took the needle out, but they couldn't get rid of it because it was all one piece. So the needle would be taped to my chest, and then this hard little plastic catheter stayed in. It never got soft. It never got compliant with your body. It was hard and rigid, and when you moved, like if you moved your arm, it would ride in and out of the skin. Consequently, they became infected rather easily. And to add insult to injury, we didn't have the nice, clear, occlusive dressings that you all know, the opsites, the it loses my memory right now what they're all called, but we didn't have those. I just had gauze and tape. Thus, I had my central line. Just the IV itself, making the TPN was a problem. You couldn't call down the pharmacy and say I wanted it. Nobody knew what it was. Luckily, my doctor had been a pharmacist before he got his MD. So he went down to the pharmacy and he talked with the pharmacist, and together they figured out how they were going to compound this solution that would give me everything I needed. Needless to say, in those days it was in glass bottles. Luckily, because he was a pharmacist, he was familiar with the 0.2 micron filters, and he wanted a filter on my IV because he recognized that it had great potential for growing bacteria. And I have to say that was my saving grace, and I'll explain why. Needless to say, you couldn't infuse fluid through a 0.2 micron filter without it being pumped. But there were no IV infusion pumps back then. So that afternoon, my doctor comes into my room pushing a cart, and on it is this kind of heavy metal box. It's about 10 to 12 inches square, and it was a Harvard infusion pump. It was not meant for patient care. It was meant for laboratory use only. There were no safety features, no bells and whistles. It had an on and off switch, and it had a rheostat. You turned the dial up, it went faster. You turned it down, it went slower. That was the extent of it. There was sterile tubing that went in the pump, but it was not IV tubing. So I had to kind of create my own. I would take sterile IV tubing, clean the outside with some betadine, take sterile scissors, cut it. Then I'd take the pump tubing, do the same thing, cut it. I'd stick them together and tape the connection, and that was my IV tubing. I did not change it every day. I kept using it until usually it exploded. What I mean, because this pump had no safety features. It pumped regardless, and if something blocked it, like maybe the tubing was kinked or the filter was clogged with precipitate, it kept pumping regardless until the pressure got so great that the tubing would pop apart, and literally there'd be TPN in every corner of the room. When I mentioned that the 0.2 micron filter was a lifesaver, it probably was, because once it was wet, it wouldn't allow fluid to go through it. There were no alarms on this pump, and if a bottle ran dry when I wasn't paying attention, it pumped air. So this was my crude setup, and as I said, it didn't get changed every day. I kept using it as long as it worked. I was in a university center at the time, and this was basically my life for the next 2 years. I more or less lived there. I occasionally got out for a brief time, like if a line went bad, he'd let me go home for a few days. And we still hoped in those days that if I really, really pushed oral feedings, small amounts constantly of the appropriate stuff, that I could maybe make it orally, but it didn't work, and I'd always end up back in the hospital a few days later. And after about 2 years, my doctor started talking about, you should be able to go home and do this. That kind of set up a roar among his colleagues because they felt it was entirely too dangerous to let a patient go home with a central line. And they absolutely got in an uproar about it. Thank goodness my doctor never gave up. And he started brainstorming with some of the surgeons, and they came up with the idea of creating AV fistulas for me to infuse my TPN through. For those that aren't familiar with this is the same thing a dialysis patient has in their arm. They surgically connect the artery and the vein in the arm. the result of having the arterial flow kind of push through this vein causes the vein to become engorged and have a very rapid blood flow. And that's what they did. And I would put a little needle in my arm every night, infuse my TPN during the night, and then I could take the needle out in the morning and be free. I managed to infuse my TPN using a fistula for 6 years, but it was 6 years and many, many, many surgeries. Because despite the fact that this vein had a rapid blood flow, it still couldn't really handle this TPN. And over time, the vein would become irritated and would clot off. And so they'd go in there and remove the clot and put in an artificial vein graft. And they did this consistently. It just kind of went up one arm, and they used both arms, up this arm, until finally, by 6 years or so, I mean, they were as far as they could go. They were all the way up in my armpits trying to get these to go. So finally, I got my first silastic catheter. It wasn't what you all know. It wasn't nice, firm catheter. It wasn't cuffed or anything like that. It was just a thin, little, soft silastic catheter. They had to open my chest to get it in, and they managed to thread it through some small intercostal vein and get it up to where it should be, and it worked. Of course, the problem, because it was a very soft catheter and because the route was very convoluting, it would not infuse if I had to lay at night with my arms flat at my side. I could not tilt my head, I could not tilt a shoulder, I could not tilt a hip. If I did any movement, it would kick off. And for believe it or not, I was kind of happy 2 years later when that catheter went bad. And then I did eventually get the Hickman's or the Boviac, the things that you all are familiar with. It was not easy to get a catheter in me because of all the years of abuse with all the many sticks up here and all the irritation of going up my arms. All the vessels in my chest, the major vessels, have clotted off. In fact, my whole body's like that. I kind of look like a walking varicosity because the small vessels have taken over the flow of all of the large veins that have been blocked throughout the years. With our advances, it became more easy to get a catheter in me. I'm sure many of you have dealt with interventional radiologists. They're wonderful. They can get a catheter in a turnip. And so life has gotten easier. I'm sure there's a lot of things I'm not covering right now, a lot of events that happened, a lot of problems we encountered. It took me 6 years to get any lipids, and then I only got them as a research patient because the United States would not approve lipids. They were being used in Europe with no problems, but the FDA wouldn't approve them. By the time I finally got some lipids, my essential fatty acid levels were so low, I'd lost all my hair, and of course, all my mucosa was just like raw meat. So there were problems along the way. And as I end this, I'd like to tell you about a conversation I had. After I'd been on TPN, about 5 years or so, my doctor told me that there was a physician from Europe who wanted to speak with me. This was Dr. Retlin, and he was a Swedish MD who was one of the pioneers in IV nutrition. In fact, intralipid was his formula. And so we met, we had a nice lunch, and during lunch he kept on asking me all these rather everyday questions about living on TPN and what life was like and just common things. And I couldn't understand why he was asking me. So finally I asked him. I said, "Why are you asking me this? Certainly you know the answers. You're one of the fathers of TPN." And he looked at me and says, "You don't understand. I've never talked to anybody that has lived on TPN. In Europe, we would never have considered keeping you alive on TPN. We only use it as a temporary measure while people are recovering from surgery. I remember that conversation. It was a real moment. And at that time, I wondered, why am I so lucky and so blessed? And I didn't know the answer then, and I still don't know the answer, but I'm glad, and I hope you all have a very positive future and that things continue to get better. Thank you. Thank you, Joan. Thank you.
The first question I have to ask you, were you this calm throughout the 50 years? Really? So mad?
You know, honestly.
Oh, well.
Yeah, I really was.
Really?
Yes. I don't know why, but I was.
I don't know why either. Okay, we have any questions, comments, anything? We have a wireless mic around for questions. There it is. Nothing.
Oh, good.
Oops, we have a few. We're just we're a shy group.
Well, Sharon, I've had the privilege of introducing you at 2 different meetings where you spoke for us. And I was just thinking as you were talking, it's a good thing you were a nurse. Because you were probably a lot more into the idea of you were being experimental. But
yeah,
it was
but
kind
I
of
think it was my personality, too.
Well, it may have been, but
Yeah.
You're amazing. I still say that, even though it's been several years since we've met personally. But I think you were, I granted, lucky at times, but
Very lucky. I really think I'm...
The alternative was step, really. So.
Well, you know, I listened to the awards yesterday, and there's some remarkable young nurses here the same way, so I congratulate you all.
Good. Next question. Oh, we have several. Oops, we're going this way.
I have 2 questions. One is, what kind of catheter do you have now, and how many hours a day do you infuse?
I have a Hickman, and I infuse about 11 hours. I connect in the evenings and take it out in the morning. I mean, disconnect in the morning. A Hickman.
Okay.
I should mention, I had twin babies, and you would think that being connected to a tube at night would be a problem, but because my kids grew up with it, it was just never a problem. They thought all mommies had one.
Good morning.
Hi.
My name is Claudia, and I'm a nurse.
Oh, great.
And I'm interested to know, over the years, how were you able to avoid sepsis with all these types of lines that you've had?
Well, I couldn't avoid it. I had some, particularly in the early days. But since the advent of the nice cuffed catheters, it's just made everything so much nicer. But no, it's not to say I haven't had my share of central, line infections. It's just, I don't know, maybe it's just instinctively my technique, but I don't think so because I've had infections.
Did you learn as you went? And
Oh,
figure out
everything.
what was working and not working?
Everything was learn as you went. I can think of, when I was home doing it myself, I reused my tubing. I'd pack it with formaldehyde at night and rinse it out and use it again. And I mixed. You've got to remember, in the early days, I didn't get TPN already pre-mixed. I mixed it from scratch, and I did it in my bathroom. Think about it. Doesn't that make you cringe?
Now, again, Oley's disclaimer is do not try anything till you talk to your clinician.
Yeah, don't do
right?
it.
Right.
I'd like to interject something which you might think was not so gentle. You actually have only come to the Oley Foundation twice.
Mm-hmm.
And when we discuss it, you always say because you're really too busy. But I think there are some more fundamental reasons. And what is your take on that issue?
Well, oh, this is, yeah. I guess I haven't come because I feel like too often some of the people I've met seem to live their disease. And I've just never been that way, and I didn't want to do that much focus on it. It's hard to explain, but I didn't feel like I needed to constantly be talking about it.
Well, can I have a follow-up? Because I think you're doing what a lot of teenagers do. They come as children, and they're willing to be part of the family at that point, and then when they reach a certain age, and they're managing fine, and they're off to the career and so on, they actually evaporate. And maybe, I don't know if we see them later. But I think the question that I have, and it would relate to you in this way, what could Oley do, long distance as it were, that could still be very helpful without necessarily pulling you in?
And I think just knowing that we're here.
Yeah, I agree. What Joan just said is just knowing that you're available. Now, I do that. Whenever I've had, where I used to work, doctors would come up to me and sometimes say, I've got a patient that's going to be going home on this, would you talk to him? I would. I mean, this is within my own hospital where I work. But the first and most thing I would do is tell them about Oley and give them it. I had a next door neighbor who had bad Crohn's and was working her way towards nutrition, and I talked to her about that. That's the most I felt I could do, is just being aware of this. Now when I ask people, everybody I talk to seems aware, although Joan pointed out to me there are so many people who don't know about it that aren't getting the support we need. Are you trying to make me feel guilty, Lynn, for not coming?
No, thank you.
Sharon, of course, I think you're amazing, but I
Thank you.
wanted to, as a dietitian and having worked in this for a little while, so we used to say don't eat, then we said you can eat whatever you want, then we said don't eat again. So can you tell me your journey with, I know you didn't absorb, but was there ever a time when they said don't eat? Because I know that was a time when people were just sad. I mean, it's bad enough. And then
Nobody ever told me to not eat. Thank goodness my doctor had a good handle on it, and he helped me understand why some things would make me so sick and other things wouldn't. And I've also, just kind of the hard way, by experience, I've learned what I could eat. I do get some absorption, and he used to theorize that I kind of stayed out of trouble with trace minerals because of that absorption, because in the beginning there was no trace minerals to be given in my IVs. I mean, he finally actually made some in the lab for me. But so, no, he's kind of, in fact, he always pushed me trying to eat more and more things. And I should mention that along the way, we tried every basic elemental diet that there was out there. I even put an NG down at night while I slept to drip the stuff down. And it didn't work, but we did try very hard with the oral regime.
again, you're amazing.
Thank you. I was just lucky.
Just lucky, she says.
I am. Okay. Good.
Well, thank you again, Sharon. You are history. And our next speaker probably does not need an introduction, but I'll try anyway. Dr. Doug Seidner is Associate Professor of Medicine in the Division of Gastroenterology, Hepatology, and Nutrition at Vanderbilt University Medical Center nearby in Nashville. He's recognized for lots of things, a fellow in the American College of Gastroenterology, American Society for Parenteral and Enteral Nutrition, serving on various committees for both organizations. But most importantly, Dr. Seidner served 6 years as on the board of directors. That's what I pick up from your bio. So his research interests include involvement of clinical outcomes in patients, home nutrition support therapies, and intestinal rehabilitation. Dr. Seidner, taking my coffee.
Good morning. How's everybody doing today? Joan and organizers, thank you very much for the invitation. So this is the, when you come to speak, you're not allowed to choose your own topic. It's given as an assignment. So Joan has asked me to tell you about parenteral nutrition-associated complications, and over the next 8 hours, I will cover this topic in depth. So here's the title, Stones, Bones, and Other Complications. My disclaimer is that this is from a lecture that we recently gave. I gave with Erica Johnson at the Cleveland Clinic, Laura Matarese at East Carolina Medical School. The title of our talk was Bacteria, Bones, and Stones, Managing Challenging Complications. So I'll take excerpts from those presentations. I do want to say there is a lot of material. I could talk for a couple of hours, but I know that Darlene will not let me. She's going to be waving signs like wild down there. I've got a lot of information on the slides. You're going to get the slides, so I'll go through and I won't read everything to you. You'll be able to do this maybe later in the day or when you get home. Things I will not talk about. So of course there are many complications. We touched upon a couple of them with Sharon, going over her start of TPN and the life that she's led. This information is available to you on the website. I trust that most of you know this, but if you don't, I've got a little slide that helps point you in the right direction on Oley's webpage. So what are stones? We're going to talk about kidney stones or nephrolithiasis. Bones, we're going to talk about osteoporosis and osteomalacia. And then bacteria, we're going to talk about SIBO, small intestinal bacterial overgrowth, and D-lactic acidosis. Okay, who knows what these are? Anybody? Aren't they pretty? Some of you may have had these. These are calcium oxalate crystals, and they are the most common stones in individuals with short bowel intestinal failure. So stones occur in about 8.4% of the population. These are some of the compounds that are in stones. Common ones are calcium oxalate and calcium phosphate. They're more common in individuals who've had gastrointestinal surgeries. If the colon is in continuity, you're more likely to have calcium oxalate stones, whereas if you've got an end stoma, an end ileostomy or jejunostomy, both calcium oxalate and uric acid stones. Up on the top right, you can see a little cartoon. Toward the right is the kidney. There's some stones there in the collecting system of the kidney, and then it goes downstream. It's actually above the next little part in the cartoon, which are the ureters, which bring urine down to the urinary bladder. And the stones usually get caught in the ureter, and that's where you're hung up in the ureters, and that's where you get discomfort. There's a plain film of the abdomen. You can see the spine and the hips, and toward the left is a little radiodense stone there. So as I alluded to a moment ago, you've got where the colon is in continuity. Most commonly, 25% of these people have stones. They're mostly calcium oxalate. Dehydration can make you prone to getting stones, so that's a very, very important thing, so I put it at the top of the list. And if you have a tendency to be dehydrated, you're more likely to get stones. If you've had stones before and you don't maintain hydration, you're more likely to have recurrent stones, so extremely important. Next, you've got increased amounts of oxalate within the lumen of the bowel because the calcium, which typically will bind to the oxalate and let it pass harmlessly in the stool, is sopped up by unabsorbed fat because you've got fat malabsorption. And so you've got more free oxalate to get absorbed in the colon, and I'll touch upon this again in a moment. You've also got increased absorption because the mucosa of the colon is irritated by bile salts that you're not absorbing. And this is especially true if you've got a little bit of the ileum resected because you're maintaining the bile. You've got this bile salt pool that helps you emulsify fat in your diet. And when you take out a lot of the terminal ileum, you don't have as much bile salt. So this is more important if you've had a partial resection. Bacteria are abnormal once you've rearranged the plumbing on the inside, and this may contribute as well. And then there's nutrient deficiencies that theoretically can make you more prone to stones. Now, if you've got an end ileostomy or jejunostomy, you're a little bit less likely to get stones. Surprisingly, you can still be at risk for calcium oxalate stones because it's generally thought that oxalate's mostly absorbed in the colon, and then you get uric acid stones. And these are just some of the factors involved in predisposing people to stones. So here's a little cartoon. You can see up at the top left is the normal situation, which I mentioned. You're absorbing fat well. The FA is fatty acids getting absorbed there in the small bowel. And the calcium that doesn't get absorbed, you only absorb about, those of us who are normal only absorb about 30% of the calcium we take in our diet, so that calcium binds to the oxalate, and the oxalate just passes harmlessly through the colon. If you've got short bowel malabsorption, top right, and you've just got an endoileostomy, you see the calcium, even though it's free, most often passes into your appliance there, and theoretically shouldn't be at great risk of stones, but some people do just normally excrete extra oxalate. So there at the bottom, you've got where the colon is hooked up, and as I mentioned, you've got free oxalate that's getting absorbed by the colon. So there's a visual for you. Here's an old study from the New England Journal of Medicine, taking 18 individuals who've had ileoresection measured against control, measuring, you'll see on that, it's called the y-axis there, urinary oxalate concentration. Normal values are less than 40, and so you can see the normal people down there grouped very low. And then to the right are the people who've had the ileoresection, and 66% of those have high urinary oxalate excretion, and the 3 patients with the circle around the dots had kidney stones. 4 of those subjects with endoileostomies who had high output were measured every day, 24-hour urines for 5 days, and you can see their urinary oxalate secretion toward the right of the figure is high. And when they're put on a low diet, so going from about 100 to 200 milligrams of oxalate in their diet down to less than 4 grams, you can see they all dropped to the normal range, and then they started on a regular diet again. And here, just a long laundry list of fruits, vegetables, meat, beverages. Remember, it's all going to be on apparently this is going to be posted. You shouldn't have to take pictures. It's okay, you'll have it. The thing that gets me is look at that on those beverages. Chocolate milk, coffee, oh my goodness. So anyway, these are foods. If you need to restrict oxalate, these are some of the foods. And if this is necessary, definitely work with a dietitian. Interestingly, because the bacteria within the bowel are altered as a result of your surgery, that might affect whether you are absorbing more oxalate because you've got different types of bacteria that are less likely to process the oxalate in your diet. And here some scientists went and took these various strains of bacteria and measured their intrinsic ability to metabolize oxalate, and they listed ones that are more likely to do this. In clinical practice, this has not been proven to work, but it's in theory, it's something that may help by taking certain probiotics. Hasn't really been studied well. One report with VSL3 showing a slight reduction of oxalate excretion in the urine, but does that mean it's going to help you if you've got these stones? Long term, we really don't know. Some of the symptoms of kidney stones, starting with back or flank pain radiating to your groin. The pain can be quite severe, makes you want to go to the emergency room, and a list of some other common symptoms. There are other associated medical conditions, some of which can be managed. This is a disease that generally affected men more than women, but now with the obesity epidemic in this country, women are unfortunately catching up with men because the obesity in women seems to affect them more. There are medications that should be reviewed that may be contributing to developing stones. If you've got a family history of stone disease, you're more likely to get stones. And if you've got structural abnormalities of the urinary tract or get frequent urinary infections, that may change the chemistry within the urine and make you more prone to developing stones. There's, of course, testing that can be done. The best test, if you're coming to the emergency room, is a non-contrast CT of the abdomen and pelvis to help identify these stones, see if there's any obstruction of the ureters and whether intervention needs to be undertaken. If the stones are small, usually less than 10 millimeters, they're usually left to pass. You give the patient IV fluid for hydration, pain medication. There's some medications that can be given to help relax the muscles of the ureters to help pass the stones. There's non-invasive procedures urologic procedures going antegrade up the urinary system to pull these things out, or there's shock wave lithotripsy, and rarely surgery has to be done. And then here's a list, fine print. Again, you're going to get the handout. Top of the list I've got is maintain hydration, very important to prevent stones. We talked about, we didn't talk in detail, but high on the list is if you've got a tendency to have these stones, have a colon in place, go on a low-fat diet, because less fat means there's calcium is more likely to bind to the oxalate. You can also take calcium supplementation to help. Cholestyramine, we talked about bile salts irritating the colon. So bile salts can bind these bile salts and also can bind oxalate a little bit. You have to be careful with these bile salt binding resins because they absorb lots of other things, other nutrients and medications, and occasionally they can make your diarrhea worse. Low oxalate diet, that's sort of low on the list of things that I do. I put these other things in place first and see if you're still having stones. Might ask you to do a 24-hour urine to see if you have a high urinary oxalate. If you have a high urinary oxalate, then I might put you on a diet then. If your oxalate has come down because you take low-fat diet with calcium supplementation, then you don't necessarily need to restrict your diet because we're already asking you to restrict your diet. A little controversial, so low sodium sort of goes counter to staying hydrated. Excess animal fat can make you prone to stones. So those recommendations are most helpful if you've got an intact GI tract for a normal population. Potassium citrate helps alkalinize your urine. Sometimes stones are more likely to form if the urine is acidic. So potassium citrate. Sodium bicarb, same reason. Magnesium supplement, a little controversial, not really a mainstay of treating, and of course magnesium supplement's going to make your diarrhea worse, so not something that we commonly push. And then I have question mark there with probiotics. So that's my quick blurb on stones. We'll go to metabolic bone disease. What we're talking mostly about is osteoporosis, which is a worldwide condition. There are some risk factors, some of which we have control over, other ones we can blame on our parents. There's some preventative things that you can do as far as diet and remaining active, and then there's things that you shouldn't do. Smoking and excess alcohol are risk factors for osteoporosis, more common in women than men. Of course, you all know this. Some definitions. So there's really two major forms of metabolic bone disease. Most commonly osteoporosis. Here's the NIH definition from 2001, a skeletal disorder characterized by compromised bone strength. So both the density and the quality of the bone are altered, predisposing an individual to fractures. These are usually called fragility fractures. You get them atraumatically. You break your bone and then you fall. It's not that you fall and you break your bone, or you sneeze and you break a vertebral body. Minimal trauma. Osteomalacia is a defect in bone mineralization where the bone-osteoid interface, I'll show you some pictures in a minute, there's increased bone volume but an increased fracture risk because the bone doesn't calcify normally. And here's just a short list of metabolic conditions that can cause this form of metabolic bone disease. So here's a photo, an X-ray on the right of a pelvis and femur, or the hip bone, and then on the right is a biopsy of the bone, and the blue is the bone is stained. So with calcium, it's stained that nice blue color. The honeycomb space that you see is where the blood elements are made. You know, blood-forming elements are in trabecular bone. Here's a patient with osteoporosis, so that's distinctly different. You could see that blue is not there. So the bone density is down and the bone is fragile. And here's osteomalacia, so you can see this osteoid, and you know what's getting calcified is actually protein, collagen. A type of collagen is what is laid down, and then that gets calcified, and you can see that this bone is poorly calcified. Osteomalacia means soft bones, so that's osteomalacia. How common is this in individuals with intestinal failure and intestinal insufficiency? So some definitions from our colleagues in Europe. They convened and got together and said, we've really got to talk the same language to each other. Short bowel syndrome means one thing to one doctor, another thing to another doctor. So they got together, and intestinal failure means your intestines aren't working well enough to sustain yourself on diet, drink, and food. So you require some parenteral support. That's intestinal failure. Intestinal insufficiency means you're absorbing poorly, but you can remain off of parenteral support. So the bar on the right are normal control subject. This is from a large group of patients from Denmark, one of the large programs over there. Dr. Nygaard reported just a year ago. On the right, those are normal, and the black at the bottom there is the osteoporosis, and that hatched bar are normal and patients with osteopenia. So the bone's a little thin, but it's not, you're not considered, not really considered a disease per se. So most people are normal or osteopenic. And then we've got intestinal insufficiency, so those are the individuals who don't need parenteral support. And you can see that osteoporosis, dark, is much more common. And then the gray bar is the osteopenia. So a very high rate of these conditions, and then intestinal failure to the right, and then just combining them all. So this is a common condition in individuals with intestinal failure and intestinal insufficiency. And why is that? Well, it has to do with what gets you to requiring parenteral support. Here are some of the common conditions that leads to requiring parenteral support. And you can see in the fine print I've given a variety of reasons why you're likely to have metabolic bone disease. And I'm introducing a new term here, IFMBD, intestinal failure associated metabolic bone disease. So that implies that it's not just the TPN, but it's the TPN and the medical condition. I'll let you read this at home. Darlene isn't waving the flag at me yet, so I've got 3 hours left. Here are some risk factors. So clearly, deficiency. So if you're protein malnourished, you're more likely to get to develop one of these metabolic bone diseases. Vitamin D, of course, calcium, magnesium, all very, very important. And then there are other nutrients that clearly affect bone metabolism, where deficiency probably makes some degree of contribution. Vitamin K, which didn't used to be in the parenteral multiple vitamins until about 5 or 10 years ago, so we don't have to worry about that now. Vitamin C, copper, you know, if you're on long term, it should be measured periodically. Fluoride, of course, as a public health service to all of us, the water has fluoride in it to help make our bones strong and teeth in good shape for our kids. And then a trace element, boron. And then potential toxicities. I list these again just to be complete. There's no quiz at the end of the presentation, don't worry. There was an interesting report out of France where patients with intestinal failure were encouraged to take mineral water as their oral rehydration solution. Very convenient to get because they've got all these mineral springs, and industry is, you know, putting out bottles of this stuff that you can go home and drink. And at the university there was somebody who was interested in fluoride, and they said, gee, let's measure our patients who have intestinal failure and taking the mineral water. And remarkably, a large number of patients taking mineral water as their oral rehydration solution had high fluoride levels. Now, is that a problem? The answer is yes, because excess fluoride can make your bones brittle. So you have to be, careful in what you do. So vitamin D, this is the Achilles heel for all of us trying to keep your bones healthy, is to try to push you to vitamin D sufficiency. It's very, very difficult, as many of you know. If your providers are measuring this and your vitamin D is low, we're doing everything we can. It's in the TPN. We're giving you oral supplements, and we're still struggling. We go out, not that we want to tell the dermatologist that we're letting you go out in the sunshine to get natural vitamin D. But here, we've got patients with intestinal failure and intestinal insufficiency. And as you can see from this handful of reports, very common to have mild, moderate, and in some cases, very common to have severe vitamin D deficiency with intestinal failure and intestinal insufficiency. Okay, so that's the underlying disease and the frequency of this. Are there factors in the parenteral nutrition that might be contributing to metabolic bone disease? And the answer is yes. When this was first recognized as a problem, of course, all the scientists at the university ran out and tried to figure out, well, what is it that's causing this terrible metabolic bone disease? Patients, after being on TPN for just a few months, were getting fractures, back pain, and they were in terrible shape. And a lot of the labs that we did were normal, and so they rushed off and tried to figure it out and gave to lab rats and humans in some instances doing these balance studies, what goes in, what comes out. And it's scary to look at the list. And I don't want you to get scared when you look at this list at this point. But you see, too much amino acid makes you lose more calcium in your urine, and you're trying to retain calcium to keep your bones. Too much sodium in the TPN can make you lose more calcium in your urine. Add more calcium comes out. Now that doesn't mean don't take calcium, but just that's the way the body maintains its balance. Dextrose does. There's one report that says cycle TPN makes you lose more calcium. There's another one that says it doesn't. Well, but we're not going to go inconvenience you so much because of this, and I'll come back to this in a little bit. One thing that was done early on is they weren't giving enough phosphorus in the TPN. So it's very important to give a sufficient amount of phosphorus, because that's what the main bone mineral is. Calcium phosphate is what the mineral that crystallizes at that osteoid surface. Magnesium, we talked about magnesium earlier. Magnesium's important to secrete a hormone, parathyroid hormone, that helps you regulate calcium metabolism. So if you don't have enough, you don't make enough magnesium, you don't make enough PTH, and also the activity on the kidney doesn't work as well. And magnesium is also involved in vitamin D metabolism. There's different forms of vitamin D that are inactive and other ones that are more active. And having a sufficient amount of magnesium is important. Metabolic acidosis, with all the diarrhea and all the loss of the bicarbonate that the pancreas and the bowel is secreting, lost in diarrheal stool, you tend to get metabolic acidosis, which can make you more prone to metabolic bone disease. There's some research out there that modest doses of heparin, usually to anticoagulate, can affect bone, something we used very low amounts of heparin long ago, and now some people use a little heparin to flush the line with. That dose is not going to bother you at all. Get enough vitamin D, and then, of course, aluminum. Aluminum's a contaminant in the solutions, and it's important that the pharmacist who's preparing your TPN knows how to mix it up right to maintain the lowest amount of aluminum exposure possible, because in retrospect, when we first gave TPN and people were getting terrible metabolic bone diseases because the amino acids were hydrolysates, which had high amounts of aluminum in them, and it was actually the aluminum toxicity that was causing metabolic bone disease. And since we've gone to amino acids that are that are created in a test tube, we don't have to worry about that as much. There are guidelines for this particular condition put out by our friends over in Europe, the ESPEN guidelines. They've got 112 guidelines. You see they put it at the end of the list. And so I just want to point out, this is not rocket science. It's important. Their first statement is diagnose metabolic bone disease, do a DEXA scan, and then monitor it with biochemistry. It's low grade because the literature is not great, but their recommendation is strong. They think it's important. Next, address any factors that may be contributing to developing metabolic bone disease, especially patients on long-term TPN. And then buff up the parenteral nutrition solution to maximize bone health. So here's the test that you do for metabolic bone disease, a DEXA scan, which is considered the gold standard. A quick test takes about 5 minutes. Radiation exposure is very low, just like a couple of chest x-rays, and you can measure these various areas of the spine. Something to point out is it cannot differentiate osteoporosis from osteomalacia. So you can get a hint that somebody might have osteomalacia based on results of the biochemical test that we do. You're going to be doing lab monitoring. We measure basic metabolic panel and a magnesium and phosphorus every week, and then less often when the TPN is stable to make sure all those values are normal. We'll occasionally check an intact PTH, the actual hormone that directs calcium metabolism, and we'll do 25-hydroxyvitamin D. If we're suspecting thyroid disease, we'll check that. Those are one of the conditions that can contribute to metabolic bone disease. There are these urine tests that you can measure the breakdown product of the collagen in the bone to see how quickly the bone is being metabolized. Usually the experts in this area, the endocrinologists and rheumatologists, will measure this occasionally if somebody isn't doing well to see that the drug is having an effect. It's not commonly done. It's not a routine test. Radiograph, I mentioned the DEXA scan. I want to just make a notation here. This, because of variation in the results between machines, it's important for you to try to get back to the place where you had your first DEXA scan so that a doctor can compare results. If you go to different institutions, it's not as comparable as other type of x-ray tests. And then I'll occasionally do 24-hour urine tests to make sure that I'm giving enough calcium and magnesium. The way this is balanced, the hormonal factors that are involved in keeping a balance, if you're not getting enough magnesium or calcium in your diet or TPN, your kidney's going to try to retain it, and if you do a 24-hour urine, your values for these minerals is going to be low. So it's good to see a normal amount of secretion or excretion by the kidney to assure that you're getting enough of these, and so we'll measure these on occasion. Just my checklist: eliminate other diseases, treat inflammatory disease, get the Crohn's disease under control if it's active, treat any underlying infections which are going to increase bone turnover, look for endocrine conditions that may be associated with bone disease, try to quit smoking, get involved in a smoking cessation program if you're on steroids for your IBD or other autoimmune conditions, try to taper or stop it, and then try to get out. Weight bearing is important. You don't have to exercise like crazy, you just have to get out and walk a few days a week. TPN preparation, again, something you can take, it's going to be in the slides, but this is what we try to strive for when we make our parenteral nutrition solution. We give a little more. The normal amount of calcium that's added to TPN is about 9 milliequivalents, and we add a little bit more than that. I mentioned before giving enough phosphorus. These are some of the doses that are recommended, but we measure blood levels and really shoot for normal range. If somebody's got metabolic acidosis, we add extra bicarbonate. Give enough sodium. Don't give excess sodium, but give enough sodium. And then once you've repleted with amino acids, if you're sick, we like to give a little extra amino acid. Once your nutritional status is improved, we'll bring this down to about 1 gram per kilo per day. So that's what we do with TPN. Some extra caveats. I'm going to skip over these. This is just added to the guidelines. These are medications that are approved for osteoporosis, mostly for men and women pre and post menopausal. That will be used. This is where these drugs work, so there's a balance. You replace your bone about every 7 years. You don't think about your bone being metabolically active, but it is. And on the left side of this cartoon there are the osteoclasts, which sort of resorb the bone and break it down, and that's where most of these drugs work, on the osteoclasts, so they inhibit the bone breakdown. And then you've got osteoblasts that are making new bone, and that's where the PTH analogs are active to make new bones. And those medicines are only, the PTH analogs are only available by injection. So I wanted to get back to this, very important. It's not all doom and gloom that your TPN is going to contribute greatly to your metabolic bone disease. Here's a report out of France showing that patients on long-term TPN, for the most part, had improvement in their bone mineral density. So on the y-axis, you've got the Z-score from their DEXA scan, and as you can see over time, that's over 10 years on the x-axis, most patients go up. The younger individuals in their program, 15 years and less, tended to go down. That might have been because more Crohn's disease, more inflammation, greater use of corticosteroids. And two other big reports out of Europe showing basically bone loss is not any greater than normal controls. So though we were very worried when TPN first came out that it was causing terrible metabolic bone disease, we learned that it was aluminum contamination, and now making the TPN, as I've suggested, should help you maintain your bone health optimally with the parenteral nutrition, along with those other lifestyle modification issues. Now, very quickly, small intestinal bacterial overgrowth, basically changing your anatomy puts you at risk for changing the bacteria in your bone, in your bowel, increased transit, secretions, which usually keep bacteria low in the upper gut, is decreased, and if you lack the ileocecal valve, bacteria from the colon can wash back up. Consequences can be small intestinal bacterial overgrowth, which can compete for your nutrients and also damage the mucosa and lead to symptoms of malabsorption, and then this condition of D-lactic acidosis. It's tough to diagnose with short bowel. You can certainly do an invasive test, do an endoscopy, and draw up a little jejunal secretion and very carefully culture that bacteria, very hard to do. Or a breath test, which is used in normal subjects, is hard to do because the transit time is so fast in short bowel. And here's some of the consequences. You can go home and read because I'm getting a card waved at me. D-lactic acidosis is a condition that we don't really know how common it is, but it is neurologic symptoms as a result of this metabolic product that the bacteria make called D-lactate. So lactate is a fairly simple sugar, and it comes in two forms. If you remember way back from your chemistry, with some of these organic molecules, there's right-handed and left-handed forms. So, D is dexter, is right-handed, and L is left-handed, and L-lactate is what is measured when you get really sick and septic because your white cells make a lot, with the metabolism, make a lot of L-lactate, and the bacteria make D-lactate, and you don't measure that. That doesn't get measured usually when you measure lactate. So those are some of the symptoms. Here are some of the criteria for D-lactic acidosis. I'm going to skip over because the flag is waving at me. This is the treatment if you get D-lactic acidosis. So hydration with sodium bicarbonate. Don't use Ringer's lactate because it confuses the situation. Restrict carbohydrate because that's what the bacteria is metabolizing, carbohydrate, and releasing this D-lactate to make you confused. Thiamine is used to increase the activity of this enzyme to help you clear the lactate. And then unclear if antibiotics or probiotics help this particular condition. Definitely used to treat small intestinal bacterial overgrowth. unclear whether it's useful in this specific condition, D-lactic acidosis. In rare instances, patients with D-lactic acidosis need hemodialysis to clear that. Here's the management. So if you've got an obstruction that's causing the bacteria to stay upstream and ferment, do an operation and relieve that obstruction. And that's not the case for many in this room. For somebody who's had a single surgery in the past and is having some obstructions of partial small bowel obstruction, that might be appropriate. If you've got markedly dilated bowel from adaptation, then one of these tapering lengthening procedures may be appropriate. You have to, the diet is really what's recommended is just a short bowel syndrome diet, treat nutrient deficiencies, and with D-lactic acidosis, we have to be careful with carbohydrate. Antibiotics are the mainstay of therapy. Here comes the hook. So these are some of the antibiotics that are there. We'll sometimes use combinations of antibiotics. We'll sometimes keep people continuously on antibiotics. Probiotics, some patients will say it works. It's trial and error. And then since acid is doing it, you might have to come down on your PPI a little bit and see if that helps you. And watch too much antidiarrheals may contribute. Conclusion. Yay! Diet modification, oral supplements, and medications may help these conditions. Medications are really only approved for metabolic bone disease. The other ones are all off-label. Modify the PN to keep your bones healthy, and with all these conditions, treat the underlying disease. Thanks for your attention.
Thank you. Stay right here. Thank you for a wonderful presentation. First question for me is, what do we do with all of this information? By the way, will be stored on the Oley website, the presentation and the slides, so that gives me a little comfort.
Go have a talk with your healthcare provider, to see how this applies to you. Don't even though Sharon, did this all at home, experimenting, and even though, of course, you all take care of yourself at home, that warning, don't do this without adult supervision, or don't do this in your home. Of course, you're all doing this in your home. With some of these things, I think you just need to have a talk with your provider, educate your provider, and do your best. Some of these are very difficult conditions to treat, of course. If you've got recurrent stones, it can be very hard to prevent recurrence. If you've got bone disease, you're doing all you can do by taking medicine. If you've got overgrowth, we try various antibiotics, and sometimes it's a struggle when the antibiotics don't work.
Very good. We have a question over here.
Oh.
With the vitamin D deficiency, my daughter saw a dermatologist, and they measured her vitamin D. She had to sit go in the sun during the summer, and it increased it a tiny bit. And so they submitted to the insurance company. They showed that the sun will improve it, so she goes for light therapy 3 times a week.
Yeah, there's a nice report. Tom Ziegler in Atlanta took a group of his patients. There's a publication out there where he had his patients that he couldn't get the vitamin D to come up, so he got the light for, the UV light to help you convert vitamin D in your skin, because that's where it's made. And yes, so that's an option for some people who are having trouble getting the vitamin D to go up.
Speaking of vitamin D, what is your recommendation? Where would you like to see your patients? At what level?
Well, we'd like to get you as normal as we can.
But I noticed on one of your slides it said less than 25 was severe. It said, if I read it correctly.
Well, that was the incident. That was measured in their population who were being treated by various means with their TPN, probably on oral supplements. It's complicated. We want to get magnesium. We're learning is very important in metabolites. So you can have low levels, and it may not be that you're not getting enough. It's just that you're not converting it, and you need to keep your magnesium in a good range too. And it may even be the ratio of calcium to magnesium that's in the circulation. So there's a lot to learn. But of course, we're always striving to be in a normal range if we can.
Well, we've just heard that many physicians, if you do your laboratory work, and if you say it's 25, they'll say, oh, that's great, that's within normal range, 25 to 50 or whatever. But Mayo Clinic, and I know for pain programs, they really like to see their patients in the 60 to 80 range. So I was just curious if you had a magic number.
Yeah, so there's depending on what lab, there's a couple things. In some of these reports, the assay's a little different, and you've got to look at the descriptors for the nanograms or units per milliliter, and some ranges are between 25 and 80, and some are between 30 and 80, and it's in a sense it's a biomarker. It's helping to predict what's going to happen in the future, but it doesn't mean that it's going to necessarily work, because you need to do all of those other things. So in patients who were struggling to get it to a normal level, and we're doing everything we can, I'm going to accept normal. I'm not going to necessarily shoot for 60, 80, because you've got to be worried that excess dose is toxic.
One other question on the urinalysis, 24-hour, obviously the calcium, but I've heard you're supposed to look at the citrate as well, but that has to be ordered. That isn't just included in the
I'm sorry,
test.
so the urine test?
In the 24-hour urine testing for your calcium, don't they look at?
Well, there's a lab. So if you go to a specialist in kidney stones, they'll do a urine collection and send it out to a reference lab that measures a lot of these chemicals that can potentially form stones, so they can give you the proper diagnosis. What type of stone are you making? There's a half a dozen types of stones that you might make. I was just referring to, in my slide there, just to try to optimize calcium and magnesium balance, right? I did not go into the details of how to do a comprehensive, medically appropriate stone evaluation. It's not in the lecture. There's a question somewhere.
Over here,
You-
and then we're over here. Okay.
You've spoken about the bone health. Can you speak to pediatric?
Nope, not an expert, sorry. No, we want to do, I can tell you just, so on that first slide that I showed you about osteoporosis worldwide, growth was important. So, of course, we all want our kids to grow and reach their potential for what's a normal height in your family. So you're going to treat the underlying disease, you're going to give them adequate nutrition. So, and the bone that we form, our bone density is maximal at about between the age of 15 and 25. That's where our peak bone density is. And then for all of us, everybody, who's over 25 in the room?
Oh, not me.
All of us, I heard you're 29. All of us are, just going gradually down, and what we're trying to do is we're trying to get peak bone mass. So that's how much I'll tell you. You want to get the kids' last question.
Last question.
Yeah, you had said that a DEXA scan can't differentiate between osteoporosis versus osteomalacia. So how do they differentiate that, and do they ever confuse the two in initial evaluations?
Do they use the what? Say that one more time.
How do they differentiate between those two if a DEXA can't tell the difference between?
So a DEXA is just telling you that the density is low, the mineral density is low. And that happens in both conditions. And then the osteomalacia would be, do you have a condition that predisposes you to osteomalacia? And the question, of course, in this room is yes. And then you look and you see, okay, tell me about vitamin D, tell me about PTH, and that suggests that you have an abnormal bone metabolism which can predispose you to osteomalacia, and you try to correct all those factors.
So do they ever then kind of tend to not evaluate that and just diagnose people with osteoporosis initially? Or is there any confusion between the conditions, by primary care physicians, and especially early on? Or is it easy to differentiate once they actually do testing?
Things have changed from many years ago. Before DEXA scan, we would on rare occasion do bone biopsies, very uncomfortable. That's where some of those pictures came from. And the drugs that we have aren't as good as the drugs that we have now. And when you're giving these drugs, by the way, you want to make sure that your calcium and vitamin D status is as close to sufficient as you can. I have some people who come in with not necessarily a short bowel, but with malabsorption, and they're on these drugs, and they're not taking calcium and vitamin D, and that's the foundation for treating these, because they need those compounds to calcify your bones. So it's true. I'm not sure I answered your question. I'll just tell you, I'll be around at the end of the session. I'll be glad to talk to anybody.
You're hosting a breakout session.
Oh, I'm hosting a breakout session. Come to the breakout session.
There we go. Kinshire room. Thank you very much, Dr. Seidner. And I have a strong feeling that if there were a quiz, we'd pass with flying colors, because you can see by your faces the interest and the absorption level of the information. So I want to thank welcome our viral audience, and hope they're at home, comfortable, enjoying the sessions. Slides and the presentation will be stored on the website. Give us a week or so, at least. And I want to comment that Oley's Medicine and Science Advisor, Dr. Darlene Kelly, worked with the Home Artificial Nutrition Group in Europe at the Aspen organization to develop the guidelines. It took 3 years and a lot of hard work. 600 and some references are published to support the guidelines. So they are the only ones. So thank you for that, Dr. Kelly. And I also want to mention that our speakers are here on their own time, volunteering their expertise, because they truly believe in educating our community. So a round of applause for that alone. The next speaker, and I have to apologize for Dr. Jay Mertello, who really couldn't be here, but feels confident that Dr. Emma Tillman can handle the entire presentation herself. Dr. Tillman is a clinical pharmacist. I hope she's in the room making her way up. There she is. Phew. So she is a pediatric intensive care unit pharmacist at the Riley Hospital for Children. She completed a pediatric pharmacy practice residency, fellowship in nutrition, metabolic support at Le Bonheur Children's Hospital at the University of Tennessee, right here in Memphis. How good. So she earned her PhD in cell biology and biochemistry from the University of Tennessee Health Science Center, in addition to having a professional tie to nutrition support. Emma's been on TPN for the past 7 years. Emma, thank you.
Well, thanks for the nice introduction. All right, so as Joan said, Jay was unable to be with us, but he did have a lot of input in the presentation, so I wanted to give him credit for that. So today we've been asked to talk about compliance. So I want to just kind of go over the general definition of compliance. So compliance is an act or process of complying with desired, demand, proposal, or regimen. So the patient's compliance in completing the treatment regimen was excellent. Or conformity in fulfilling an official requirements, or his actions were in compliance with the state law, or disposition to yield to others, or the ability of an object to yield elasticity when a force is applied, or flexibility. So all those are different definitions of compliance, and I think generally when you're talking about medical compliance, you think of the first one, of the patient was compliant with a regimen. So I want to kind of just give a little bit of background through that. So in our use of home parental and enteral nutrition, we have all these responsibilities. So you need to hook up to your TPN to infuse, you need to hydrate, you need to try to eat something, you need to check your blood sugar and correct that, take your meds, and sometimes do you feel like this is just too much? Like you just can't handle all these things. It's a full-time job to take care of yourself. So throughout the day, I want to talk about enteral nutrition and parental nutrition regimen and its complexity and time, and that it's time-consuming. It requires daily and most often several times a day activities. The disease exacerbations or complications of nutrition can occur even if you're 100% compliant. So you can do everything right and you can still have trouble. Nutrition therapy is a responsibility and it can be very stressful. Also, compliance with a regimen is important to successful disease and nutritional management. And then in this presentation, I'd like to discuss 4 major topics of compliance. So first, hydration, diet, glucose control, and then the variables that will create issues for compliance when this is poor. So compliance challenges, I think if this kind of sums up our like 4 areas of things that we think about. So hydration, our diet, glycemic control, and medications. So I'm going to start with some hydration. Some of these slides may look familiar. I've kind of stolen presentation things from other things I've done. So hopefully it'll be a nice review and you won't be too bored. So water is the most important nutrient. Water is the body's most valuable nutrient, making up about 50 to 60% of your total body weight, and 90% of your blood volume, and 75% of your brain volume. So water has a biochemical role. It's a valuable component of all cells and essential for biochemical reactions, and it's important for transport of nutrients and other cellular messengers. So we talk a lot about fluid balance, and I think first you need, in order to understand fluid balance and why hydration is important, you need to know where the water, where your water is coming from and how you're losing it. So water, just in any type of person, not just a person with short bowel syndrome or on parenteral nutrition, your water is going to come from 3 major sources. So your beverages, which you think of as a water source, the food, so even like if you're eating grapes, watermelon, a lot of those things are obvious that they have a lot of water, but even other foods have water in them. And then also you get a small percentage of water from metabolism, so cellular metabolism. As your body breaks down fat cells for energy, there's water molecules that are being made. So some of that, your body is actually producing some water. So where is your water going out? So in a healthy adult, so this is maybe for some of the clinicians in the room that don't have parenteral nutrition, this is where most of your water is going from. So a small amount from sweat, you have some from insensible losses, and this is from respiratory losses. So as you breathe, you're going to breathe out some water molecules that are going to be evaporated. The majority is coming from urine, and then a small part is going to come from feces. Well, if we think about those with short bowel syndrome who have a lot more fecal output, you're going to have a lot larger loss. And so you still want to target about a liter to 2 liters, a liter or a liter and a half of urine per day. But if you are having a liter of stool output per day, your water loss is going to be significantly greater. So that's something to consider in how you're replacing your water. So in many of these malabsorptive syndromes, this kind of gives a little bit of a look at how we're losing fluid. So if you're taking in, so if you look at the second line down, if you're taking in 1,000 mils of oral intake and your GI output is 1,500 mils, you're going to be negative 500. Well, if you take in 1,500 mils, then your output may increase even exponentially, where you're having 2,500 output, and then you're going to be a liter negative. So I think some people get into this kind of vicious cycle where you're hungry and you eat more, and then the more you eat, you get further behind. And I think that's just something to recognize, that doing more could make you even in a worse case scenario. So what is dehydration? So dehydration is inadequate fluid for optimal body performance, and it's classified as mild, moderate, or severe. So mild is a loss of about 3 to 5% of your total body weight, moderate is about 5 to 9% of body weight, and severe is greater than 9% of body weight. So signs and symptoms of dehydration include thirst, dry mouth or dry mucous membranes, lethargy, fatigue. I think the first 3 of these you probably have just on a generally hot day in Memphis. Like you're probably going to have thirst and dry mouth, and probably you're going to feel like, oh my gosh, I'm so tired. Like this heat is getting to me. I think when you start to worry is when you have muscle weakness, when you're dizzy. So if you stand up too fast or you start walking from one part of the room to the other and you're dizzy, skin tinning, reduced, and I have some pictures of this, reduced urine output, decreased weight, and then delayed capillary reflex. So this is an illustration of skin tinting. So if you pinch your skin, it should actually be very elastic and just go right back to normal. But if you're dehydrated, that pinch is going to stay there for a while. So if you're in this stage, you need to be concerned, and you need to go to your hydration plan, and I'll go into that a little bit in the future. And then slow capillary refill, so if you pinch your skin, the fingertips, everyone's will turn white, and it should have a flash capillary refill where it comes back, the color will pinken up right away. And if it's 3, 4, 5 seconds, you should be concerned that you're getting dehydrated. And then dry mucous membrane, so if your tongue is dry, other like your eyes are not tearing, or if you stop sweating, those are things that are symptoms of more advanced dehydration. So I think we think a lot about how to keep hydrated, and you need, especially people with short bowel syndrome, need more than just water. So if you think about where our losses are, I think that kind of shows you what you need to have. So I think typically most of the sports drinks out there are targeted towards the athlete. So they are high in sodium, or moderately high in sodium, potassium, and chloride. So it has sodium chloride in it, but they're really targeted for that 30 to 70 milliequivalents per liter of sweat, because that's what people are losing. So if you think about if you have GI losses, so stomach, duodenum, gastric, or ileum, depending on if you have an ostomy, an ileostomy, colonoscopy, your sodium requirement is going to be much more. So the Gatorade that the athletes are drinking to replace their 30 to 70 milliequivalents per liter of sweat is not going to be sufficient if you have a lot of ileostomy output where you're losing 140 milliequivalents per liter of sodium. You need a lot more sodium chloride in order to replace your electrolytes. And so that gets us to some of why shouldn't we just drink water. So water, this kind of is like a very elementary thing, but here we have the first picture is a happy cell. So your cell wants to have the same number of ions on the outside and the inside. So it wants to have the same amount of sodium chloride inside the cell as the outside hanging out like in its environment. So if your cell is there and you have 6 parts sodium chloride on the outside and 6 in the inside, it's going to be super happy because it wants to like keep everything a neutral balance. Well, if you add that same cell into a glass of water, it's going to say, hey, I'm not equal. I need to like put some of my sodium chloride on the outside of this cell instead of, because I feel weird because I'm not like, equal on the inside and the outside. I went backwards, sorry. So then it's going to try to give some of its sodium chloride from the inside and try to neutralize that. So if you drink just water, your cells are not going to be happy. That's sort of like a very like vague way of looking at it. But some factors that influence hydration that we need to think about are the types and quality of food that you eat, and then how that leads to GI losses. So if you eat something that's going to increase your output, that's going to be even worse for your hydration. Also, so if you eat this big fancy Thanksgiving dinner, you might have a ton of output, and you're going to be more prone to dehydration. Also, if the weather is super sunny and you're out like enjoying the beach, getting your vitamin D, you may need to have a little bit more hydration that day. Or if you're out hiking some trails and you're out in the weather and at altitude, you may need to wear your TPN backpack and hydrate during that in order to stay hydrated. So what are some like just general tips? I've given you some information on kind of the basics of dehydration. But first of all, know your baseline weight. I think this is a good, like, kind of a rough estimate of checking your hydration status. So know your morning weight and your evening weight, and not that you need to, like, worry about, we use weight as, like, a measure of nutritional status, too, but I think it can be an immediate status for hydration. So if you weigh yourself in the morning and then you weigh yourself that evening, you know you didn't lose 5 pounds of lean body weight in one day. It's probably most likely due to hydration. So those are kind of good things to know on a baseline. Weigh yourself before engaging in activity, especially if you anticipate that you're going to lose a lot of hydration that day. So if you're going out for a run, or if you're going to be a day at the beach, or you know you're going to eat foods that are going to have high output, it's kind of good to know that baseline weight. So then when you get home that afternoon or evening, you can check in your weight and then see roughly, oh, I'm down like 6 pounds. I probably need to do close to 3 liters, or however that is, like to try to get yourself back to your your baseline weight. So hydration during daily activity. So it's good to sip some oral rehydration solution slowly throughout the day. Also, you may want to wear a hydration pack. So if this is IV nutrition or enteral, and infuse during your activity. Or if you're running a marathon, you may need to have some IV hydration during the marathon. And I really like, this is my favorite part of this picture, this little guy in the background saying, what is going on this marathon course? So I think that's kind of priceless. But we all need to find, creative ways in order to try to hydrate in ways that don't impede us from doing our daily activity. So now that we know how to recognize dehydration and hopefully prevent it, but what if things don't go as planned? And so I think this is like the big test of compliance, because we can all say like, oh, we know the right things to do, but what if that doesn't happen? So mild dehydration, as I said, was about a 3 to 5% body loss, and you're going to have thirst and dry mucous membranes, dry mouth. The treatment for that is usually just rehydrate with oral rehydration solution, drink slowly, avoid the temptation to guzzle the fluid, and rest and stay in a controlled temperature environment. When this gets to moderate dehydration, you're going to have a greater loss of body weight, still dry mucous membranes, you're going to be lethargic, maybe fatigued, could be dizzy, have urine output that's reduced. Again, here you're going to try to do your enteral rehydration, but you may need to do IV, especially if you're vomiting or having a lot of diarrhea, or if you just can't keep up with the enterally, and then still rest and stay in that temperature. So severe dehydration is when it gets pretty out of control, where you're greater than 9% body weight, you're confused, you have extreme muscle weakness, dizziness, fatigue, you have this skin tinting, which I showed the picture of, delayed cap refill, and minimum or no urine output. And treatment for this, you really need to seek help. This is probably something that you don't want to just handle on your own. You need to call for help and start your IV hydration, or if you're enterally fed, at least put in enteral nutrition or enteral hydration solution too, and then seek medical attention. So we know how to prevent dehydration, and we know all of the bad things that can happen if we're not compliant. So this, this shouldn't be an issue, right? Like we can all do this. But sometimes life kind of interferes. We have the best of intentions, but we all get into this circumstance. So I'll just use myself as an example. Not that I would ever do this, but so my usual AM weight at the time is about 140 pounds. I ran for 90 minutes and the temperature was 82 degrees. Post-run, I got home and I weighed myself and I was about 135 pounds. And I thought, oh, that's probably not great. Symptoms, I was sweaty, thirsty, and tired. But probably, here, so we're going to have like this small group breakout. So I'm not going to like spend a lot of time on discussion, but we'll kind of skip through this, but we can have some discussion later in the breakout session this afternoon. But what would be my next thing at this point? So my current stage of dehydration, so doing the little sweat calculations. So here I'm about, go through this, mild dehydration. So my friends were like, hey, let's go get breakfast. I say, yeah, that's great. I want to have a good time. So I order, a Diet Coke and this huge breakfast. And then I guzzle my Diet Coke and I eat the breakfast and, I have some vomiting and diarrhea begins. I'm feeling lightheaded and dizzy, cold and clammy, laying on the bathroom floor. I'm like, ooh, that was probably a bad decision. So we'll talk about, what you should do at this point, but just kind of to go through. So what stage of dehydration was this? Well, my symptoms were, now previously I was like greater than 5%. Now I have increased output and dizzy and confused. So what should I do now? Well, I should probably really get some help. I need to start some IV hydration, and this is probably moderate to severe dehydration, or at least getting there. And, I knew all the tools, but I just didn't do it. So I think, we all get to that stage. So if you know what to do and what you're supposed to do, why don't we do it? And then what would be appropriate plan for avoiding this from happening again? And so these are some things that we can talk about in the afternoon session. So now I'm going to go into diet, which I think is kind of an interesting thing to talk about. So it's super hard to stick to special diets. For the home parental nutrition, enteral nutrition consumer, we're often prescribed these special diets that restrict normal foods. Compliance is a real challenge. Life is centered around food, and we have all kinds of temptations for that. So factors that are associated with dietary compliance might be hunger versus craving. So sometimes you're not super hungry, but you're craving that cookie, or you're craving that, that's something that you shouldn't really eat. Eating at home versus away from home. Even here at the conference, like your normal food isn't here. And the breakfast was great out there, but that might not be what you normally eat for breakfast. And so if you're trying to think about, I want to be able to stay here in the conference all day, I don't want to have like a bad belly, you kind of gravitate through things that are maybe more good for you. And then the social and peer pressure of eating. I think this is like a huge thing, which we can talk about more this afternoon. But I've used these slides before, but I think it's kind of a timeless topic. So this girl is here at this barbecue, and she's like, I want to eat so bad I can almost cry. And I think we all kind of have that thing where you go to this barbecue and you're like, ooh, this is just not a good day, but the food looks so good, I'd really want to eat, but I can't. And I think, so some literature on that. There was a study by Marion Winkler a few years ago looking at adult home short bowel syndrome patients, and they evaluated quality of life, and what came out of that study is all these patients had this strong desire to achieve normalcy in life. They just wanted to be normal. I think eating is a big issue with that. So the girl that she could eat, she wanted to eat so bad she could almost cry. Some things that you can do to combat that are, eat or infuse your nutrition prior to the party to combat your true hunger. Offer to help with the cooking, maybe bring some safe food that you can eat there so you're not tempted by the things that are going to make you sick. This is a true situation for a lot of the parents in the room. You may have a child that goes to a birthday party, and the kid's thinking, I want to eat the cake like the other kids, but I don't want my belly to hurt. And how do you do this? How do you talk to your kids about this is going to be the consequence of if you eat the food? And I think another thing is who do you disclose this to? So there was some legislature in Canada that came out in 2006. Sabrina's Law mandates disclosure of severe food allergies in school-aged children. And then a 2008 study was conducted with interviews of children and their parents, and children were stigmatized as a result of this law. So parents would say, my child has a food allergy, they have a peanut allergy, and then the class couldn't bring peanuts in for a party or whatever. And so they're like, well, we can't have peanuts because of Susie or whatever. And so, it's a thing that you have to really think about, is you don't want to put your children in a I'm different kind of boat, but you also want people to know, that they have a true medical reason why they can't eat cake at the party, or why they can't, they're lactose intolerant, or whatever their thing is. So what do we do? Be prepared. Talk to your children about ways that what will happen if they do eat the cake. Pack their safe foods. So if they can tolerate something else, pack that for them and give them a special treat of whatever they can handle. And then communicate the special nutritional needs with someone that's going to be at the party, whether that's a parent or another caregiver, or if you need to stay there with them. And then some situations are unavoidable with eating. So, a business lunch, a job interview, conference activities. So this is me a lot a few years ago, where I was doing a lot of like interview lunches, and I might do this where I'll put some food on my plate and move it around, and hopefully no one will notice I'm not eating, because you don't want to stand out, you don't want to draw attention to yourself, but you also don't want to make yourself uncomfortable. So this is another thing about disclosure. So in successful employment, if individuals with disabilities face barriers for employment, so investigators interviewed 41 people who were competitively employed for at least 5 years and discussed their disabilities. Disclosure and discussion of these decisions was influenced by their disabilities. So people with disabilities found that they must work harder than others in order to get a job. So if they initially just give these disabilities, sometimes they felt like they were somewhat discriminated against, which shouldn't happen. So what do you do to combat this? So decide how much or little you want to disclose and to whom. Communicate to someone. So have a wingman to help take the pressure off. So at my old job, I had someone that he was at a lot of these interview lunches. And so if people were like, oh, aren't you going to eat? Are you going to eat today? And he was like, oh, Emma, didn't you tell me you had a big breakfast? You weren't going to eat lunch today. And so he was just sort of like my wingman, like my helper. And he sort of diffused the situation, which was so helpful in order just to like kind of diffuse everything. And then avoiding conventional eating shouldn't make you avoid your friends. So social withdrawal is typical reaction for when you're working through some of these new eating restrictions. So avoiding social friend interactions, and they may make you feel worse about your situation. So here, a coffee date with friends, and she's like, I'm just gonna hold my coffee cup up and no one will notice I'm not drinking. But yet her friend who knows her really well is like, Liz has been holding that cup, but she hasn't taken a drink. I wonder if she's okay. So you don't want to get into that situation where your friends are really concerned about you. So I think the best thing is to be honest. Eliminate all these assumptions, communicate what makes you comfortable, and your true friends will care about your well-being and will be supportive and want to help you. And just avoid unnecessary drama. It doesn't need to be all about you or all about things that are going on with you, but definitely give them the lowdown on what's really happening. And then here's kind of a typical family dinner, and I think this is a good way to kind of end this little vignettes, is the ladies thinking, it's so nice to enjoy a meal with my family where I'm not judged on what I do and don't eat. And I think ultimately that's where we want to get to. So family and friends you can enjoy their company are not going to worry about your food needs. And then enjoy the activity, and even if it doesn't involve eating. And then start incorporating non-food traditions into your holiday celebrations and all of your social things. So for me, I'm a pretty avid runner, and I do that a lot with friends. And so instead of going out for a coffee date, I will go for a running date or a walking date. And so it makes it a little more fun. So some tools to help in dietary compliance. I think it's good to track your food with intake and symptoms. So if you know that every time you eat a bagel, you're going to bloat up or whatever, like write that down and keep that handy, so then when you go see your physician, they say, oh, these are the things that you should avoid. Be prepared, pack familiar and safe foods, and incorporate non-food events into tradition into your schedule. So now we know kind of the compliant patient. So how often should eating, will this lead to trouble, and what should we do about it? So we can talk about those things again in the afternoon session. So I'll do just a little bit about glycemic control. So the incidence of hyperglycemia and parenteral nutrition with dextrose rate. So this just gives us a little bit of facts on with your glucose infusion rate and your blood sugar. So many patients on parenteral nutrition are going to have trouble with hyperglycemia. So why is it important to check your glucose? So hyperglycemia is frequent in complication of enteral and parenteral nutrition patients. Extensive evidence from observational studies indicates that the development of hyperglycemia during parenteral and enteral nutrition is associated with an increased risk of death and infectious complications. Most of this literature comes out of the hospitalized patient, so it's in sicker patients, but I think it can be extrapolated to longer-term patients. And if you look at your diabetic patients that have uncontrolled glucose for a while, they're also increased risk of complications. But conversely, hypoglycemia is also common in patients when they come off of parenteral and enteral nutrition, and can be a dangerous complication if they're not given prompt attention. So what should you do? You should inform your physician and your TPN clinician. Record your blood sugars and circumstances around that event. So if you know that every morning, 2 hours after I come off of my parenteral nutrition, my blood sugar is in the 40s and 50s, or every day when I cycle up on my parenteral nutrition, my blood sugar is at 400 or whatever. These need to be addressed, and it's not something that you probably can't fix this on your own. You probably need to have your team help you with your cycle rate, or how to bridge with enteral nutrition on the ins and outs of your cycle, and then coordinate a plan for preventing and treating your hyper and hypoglycemia. So medication and nutrition schedules, I think this is really tough. We talked about at the beginning that it's a full-time job to do all these things. So what can we do to help this? So everyone has the best of intentions of doing everything correctly, but really life happens. Meds get missed, parental and enteral nutrition cycles get timed off. You're at a meeting, you're having fun with your friends, and you didn't get your TPN hooked up until later, or maybe your pump went dead, or all kinds of things happen. Hydration sometimes is not a priority as it should be. So what can we do to help aid compliance? So set phone alarms and alerts to remind yourself to take your meds. Use food tracking apps to organize your dietary intake, and use health apps to track your weight and fluid balance. So some of the things that I like to use, I use the MyFitnessPal, which is a free app. You can put in your calories for the day, have a goal, and put your food intake, and then it puts your exercise. I also use the alarms on my phone. If I ever have Q8 meds, those are always forgotten. So I put like a 2 p.m. Alarm, and sometimes it doesn't get done at 2 p.m., but at least it alarms at me, and then I'm like, oh yeah, I did, that went off and I stopped it. I should take that med. So those kind of things. We have all this technology, and most of us are connected to our phones all the time. So let's use those and try to help that with our compliance. So what should we do when we're not compliant? I think the best thing to do is be honest. Be honest with your team and say, hey, last night I got home really late and I fell asleep on my couch and I forgot to hook up, and today I'm dehydrated, and those things are gonna happen, and all of us are human. We're gonna make mistakes, and we're gonna miss a bag here and there. We're gonna not do our cycle over the 12 hours we were prescribed and only do 6 hours or half the bag, or those things happen. And not that it's we should do it all the time. We should strive to do things right. But if you don't do something correctly, you need to be honest and tell people, because they can't help you fix it if they don't know. Tell the truth about your compliance. If you've missed meds or you've missed anything, it's people aren't going to judge you. They're going to try to help you get back on track. And then if you aren't honest, no one really can help you fix those situations. So going back to our definition of compliance, I want to kind of end with, I think really compliance in our field or in our area of chronic illness is really this. We talk about the first definition, but I really think it's the third definition: the ability of an object to yield elasticity when force is applied. So really, life is the force, where there's a lot of juggling things that we have to do. In the order for us to be flexible and try to keep our hydration, diet, meds, and nutrition and glycemic control, all of that in check, I think that's really what we need to do and to be compliant. So I'd love to continue to hear what everyone else has to say. Maybe we can share some tips. We have a breakout session from 2:45 to 3:45 in the Lansdowne room. I'm not exactly sure where that is, but we'll find it. Third floor. Okay. So third floor down this corridor over here. So hopefully it'll be a rousing discussion, and we can kind of talk about all the different topics. So I look forward to that.
Thank you, Dr. Tillman. Thanks so much. Questions?
Emma, hi. Just one thing that Emma was sort of implying, but I'd like to say it in so many words. For people with short bowel syndrome, water is a terrible hydrator. If you drink a glass of water, you will have more than a glass of output from an ostomy or diarrhea if you have intact small bowel or colon, because you will lose more fluid than you drank. So the oral rehydration solution or something like this is definitely a much better answer to hydration. Was I correct about
Yeah.
I was implying?
Yes. Sorry, I didn't spell it out quite as. This is good.
Do you have any experience with consumers that do have intact bowels but have motility disorders? It seems like I know so many of us that have increased hydration needs, even though we don't have that high output. We often have a lot of symptoms of dehydration.
Yeah, and I think it depends on your motility. So if you're, if your motility is leading to a lot of vomiting, probably we'll have more output that way, or increased motility. There's some people that have really rapid motility who lose more. So I think just knowing your own, you're having a good check on your own weight and knowing what your baseline is, and everybody's hydration needs may be different, and even just people without bowel trouble, some people are heavy sweaters and some people are not, and so everybody's hydration needs are slightly different. But I think trying to know your own and work on a plan with your healthcare team.
We want to thank our co-president, Bob Smithers, for running around the room with the microphone.
It sounds like it's the duck time too. I feel like we should like take a little, they're doing like the duck march right now.
Yes, I just want to add something. My son had the symptoms of severe dehydration, had not been sick for about 5 years, completely 5 years with no problems, and he has short bowel syndrome, and he is enterally fed. So, and being a former nurse and everything, like the one said, you never do anything when you're a nurse. But anyway, he came home, he said he was dizzy. I said, go lie down a little while. And when I saw him, he had a profuse diarrhea, and we had him change his clothes. By the time we got to the hospital, he couldn't walk, and he was in a coma in about 15 minutes after we got to the hospital. So don't be afraid to call an ambulance. And that's what I should have done that day. I should have called an ambulance. Fortunately, it came through and he was fine. But, and thank you for the tips, because that gets us, but it is an emergent situation.
Yeah, definitely.
I have a quick comment, it's not a question, but our former president, Rick Davis, was in the hospitality industry, and eating was and entertaining people was a very important part of his job. And suddenly a stroke left him with the inability to swallow. And he shared a couple of really important tips. One was he learned, it took him a year or so, he learned that he had to get comfortable with what he was dealt with, an inability to eat, because his social life was so important to him. So he got his ducks in a row, got comfortable, and so that invitations to functions that he enjoyed so much kept coming. And to add to some of your tips, he learned to serve, to do dishes, and to just make a fun, presentation. And he thinks he got more invitations because he did dishes. So I couldn't. Oh, there you go. Oh, that's probably the most important pearl.
I get to move around when I do this.
I just said that he took his beer through his feeding tube, and he would invite us all into the bar for a drink, but his came through his feeding tube.
Any other questions? Whoops.
I have a quick question. My son has a jejunostomy, and so I'm curious if rehydrating solutions are appropriate for him, or are they not absorbed in the jejunum?
Probably the best bet would be like an oral rehydration solution, one that's going to have close to like 140 milliequivalents of sodium per liter.
Oops, could we have the mic?
70 to 80. So, okay. So she said 70 to 80, but definitely not a Gatorade where it has 30 to 70. That would be like too little. And then watch the amount of glucose in it. So if it has some of the sports drinks have too high calorie or too much sugar in them, where you want one that has a lower sugar content. So like the WHO solution would be like the, yeah.
One more? Here we go.
It's more of a comment than a question, but our daughter is super picky 7-year-old, will only drink regular water most of the time. I've tried all different ORS and she just won't take them, but the only one I've gotten her to drink that gives her some benefits is by Propel, and Gatorade makes it, but it's the unflavored. They sell it at Target a lot. But it tastes just like water, but it has the same electrolytes that Gatorade has. So if anybody else has, a picky
I think that's
taste, it's Propel. Propel, and it's the unflavored kind. And I know Target sells it. I have trouble finding the unflavored ones. I haven't seen it at Walmart or anything, but it has the same electrolyte concentration, no sugar added.
Yeah, it probably still doesn't have quite as much salt in it.
No.
So,
No, it doesn't.
if you can add salt to it, would be good. But if she can't, if it's that versus water, some salt's
Yeah.
probably better than none.
Yeah, it's
so.
a compromise for us, but
Yeah. All right, well, we can probably cut off the questions for now and then have the discussion this afternoon. Would that work?
That works. Thank you very
Perfect.
much. Thank you very, very much. And the last but certainly not least presenter today is Dr. Teresa Cutts. Dr. Cutts completed her postdoctoral fellowship in health psychology from the University of Tennessee, right here in Memphis, and then went on to work as a staff psychologist at Baptist Memorial Hospital, held an appointment in the University of Tennessee in psychiatry. She's been in partnership with Dr. Tom Abel, who has been a very well-known supporter of the Oley Foundation in the motility world. His name is huge. And she's conducted a clinical team research in the area of quality of life and catastrophic gastrointestinal disorders, leading monthly support groups for motility disorder patients from 1990 to 2002. Come on up. She was a private practitioner, Memphis Center for Women and Families, with a focus on health psychology, prevention and management of physical illness, pain, eating disorders, trauma treatment, conducted critical incident stress debriefings in the community, and it goes on and on and on. I cut it off there, Teresa. Thank you for joining us.
Okay, good morning, everybody. I am delighted to be back here in Memphis. When Joan called me, actually she put me in touch with Tom, Dr. Abel. Many of you do know him, and I've got to start by saying I am just a poor substitute for Dr. Abel today. But I talked to him Friday because his youngest child, his daughter, just graduated from her residency in Washington, and he sends his greetings to everybody. The other reason that I'm also delighted to be back is you'll notice that my address in the booklet there is Memphis Center for Women and Families, and I have not been there for 16 years. I was actually here and spoke to the group 24 years ago with Dr. Abel when I was still based in Memphis, and that's when I was in private practice. So I now am based at Wake Forest School of Medicine, and I will just say as a disclaimer, I'm going to share with you sort of the journey of the work that we've done over the last 30 years. I'm feeling a little bit old now as I think about that, but with Dr. Abel and his team. But we continue to publish, actually, and look at some of the early data that we have, and I'll share with you some of my biases and some of the things we hope to do in terms of sharing about GI motility disorders. I have not worked in the clinical field, though, probably since the mid-2000s in terms of this work, so I may have to rely on some of the other experts in the room. And I would just say that the reason that I have this sort of tongue-in-cheek title is it's true. Most of what we have learned actually from people that have gastroparesis, what we used to call chronic intestinal idiopathic pseudo-obstruction, cyclical vomiting syndrome, many other different flavors of folks that have different GI problems, motility disorders. We've learned mostly from the patients. Now, we have learned a lot from providers, but mostly the patients are the experts. And that was when we did the support group for over 12 years. That's what we really learned, and I want to share some of that learning today. The other thing I will say, too, is some of you are very familiar with Dr. Abel's writings, and as I understand it, he just published something in the Oley Foundation newsletter about sort of the history of what we now call gastroparesis, just as a generic kind of phrase. And so I'm going to just call what GI motility disorders today, I'm just going to call it gastroparesis just as an umbrella term. We also know that a lot of people have gastroparesis type syndromes, and I've mentioned some of the other syndromes that kind of fit under that umbrella, but just for the sake of time, I'm going to use that as a sort of a general term when I talk. So again, I've been at this work for about 30 years, and I'll tell you how that started in a minute with Dr. Abel, of course. I will say that we began early on talking about what was called health-related quality of life, and 30 years ago that wasn't a very familiar term. And in fact, the first article that we ever published was in 1994 in one of the European journals about health-related quality of life and gastroparesis, and the severe impact it had on people's just everyday functioning and how they functioned in the world, and the tremendous disease burden that went along with these illnesses. Then I'll share some basic lessons that we learned from the support group folks. Then we recently, last year, published an article looking back over the last 25 years of what we've learned, how we use patient-reported symptoms and provider-reported symptom scales, and how we've kind of combined all that to be patient-reported outcomes, which is very familiar now, but 25, 30 years ago, that wasn't what it was called, and it was sort of a new idea. And then lastly, I will just say, and you all know this, you live it, partnering with your team, and it takes a team to deal with a lot of these issues. And I need to salute Ms. Rose and Dr. Tillman, Dr. Seidner. It's a team process, and the most important parts of the team are really the family and the person that's experiencing the illness themselves. So it's always going to be, we're always going to go back to a team sport. So my team sport started with Dr. Abel. 30 years ago, in this August, I had started a postdoctoral fellowship in health psychology, and my boss said, oh, there's this guy, he's a gastroenterologist from Mayo, and he's working with these sort of different types of disease. These are rare diseases. And I'd never, of course, ever heard of gastroparesis or any of those diseases at that time. And so I sat down and had lunch with Tom, and you can see he hasn't changed much. He just has a little bit whiter hair than he did 30 years ago. But he looks about the same. And he educated me basically about gastroparesis. And he said, well, most providers think that these are not real diseases. They think that there's a psychiatric overlay. They think that people don't really have anything going on with their gut. And he shared with me that he wanted me as a psychologist to be a part of the work to try to prove that wasn't so, because he'd been very convicted since even the late 60s that was not the case. And so I became part of that team. There's a lot more still to be learned about gastroparesis and gastroparesis-type syndromes, but what we do know is that it is a very heterogeneous group of illnesses, and I think that's part of why there's so much difficulty in terms of dealing with it. If you've seen one person who has gastroparesis, you've seen one person, because they have a lot of different presentations, a lot of different things that are going on. The Gastroparesis Clinical Research Consortium started about 11 years ago through the NIH. Many of you are familiar with that work, and I will say that happily they've published a lot that I think have helped people in terms of understanding the etiology of the disease or the progression of the diseases, looking at the different subtypes of the diseases. But I do think that part of the reason that early on there was this kind of focus on it being a psychiatric problem, not a GI problem, was that we just didn't have the technology to measure what was going on with folks. And we still are lacking in that area. I wish we had gone farther in 30 years. Tom actually, and most of you that know Tom knows he loves acronyms. He's always making up acronyms and phrases. And so he talks about the 5 M's of people that have gastroparesis. They're miserable, misunderstood, misdiagnosed, mismanaged, and mistreated. And I think he shared that in that newsletter article that he just published with you guys. And so one of the things that was really important 30 years ago was he called me in as the psychologist on the team. So we'd bring the dietitian in, the pain management specialist, but the psychologist came in on the front end because the traditional lore at that time when I was doing med-surg consultation in the hospital was that they would do so-called structural tests, right? They would check and see what's really going on with you, what's really the organic cause of your disease, and they'd exhaust all those tests, and if they couldn't find a finding that was structurally abnormal, they would call in the psychiatrist or the psychologist. And what did that signal to the patient, right? What we used to call, I remember doing a workshop in the 1990s at the American Gastroenterological Association called It's Not All in Your Head, right? And I think that's one of the issues is that you know, these illnesses are not all in our head, they're not all in our gut, they're all in all of our organ systems. And in fact, now I work in faith community research with health systems at Wake Forest, and so we even say, you know, a holistic approach to these diseases is really, really important because we're all biopsychosocial and spiritual creatures, right? And so one of the things that we've constantly kind of focused on is how do you kind of debunk these myths, right? And many of you probably have not experienced that, but a lot of people that have gastroparesis have. At the early days, I had trained in doing musculoskeletal pain management, where you teach people passive muscle relaxation and visualization. And when I started working with folks with gastroparesis, oh my goodness, if somebody's in the middle of a terrible vomiting episode, you can't talk to them about being in a happy meadow, right, and getting relaxed, right? So very quickly, I learned that my bag of tricks in terms of being trained in terms of basic pain management as a psychologist really did not work very well for our patients. And actually that kind of led to us developing the support groups, which started in 1990, which I'll talk about a little bit more in a minute. And I think it's also really important to think about when we first started working with gastroparesis patients, we thought of it as catastrophic illnesses because it had such an impact on people's lives. Couldn't eat. Many of them could not work any longer because of the terrible fatigue that goes along with nausea and vomiting and the other syndromes that folks had. And so it was really important to kind of talk to folks about sort of chronic care management. And those of you that work in hospital setting, the Institute for Healthcare Improvement talks about how you have a dyad between your provider team and then you have a patient who's activated and informed and kind of meets that provider midway. And I think there's much more of an appetite for that now than there certainly was 30 years ago when it was kind of the M-deity. They used to call it the M-deity, that the doctor knows all, and there wasn't a lot of teamwork that was going on. Right? Some of you remember those terms. And so in terms of self-management, I think there were some things that we did share with the patients that they learned. One was pacing. What we found was because most people, many of you understand it, but nausea and vomiting, it causes such tremendous fatigue for people. And so a lot of our patients, if they were having a good day, and I think Dr. Tillman actually kind of illustrated that a little bit, you kind of get up and you overdo, right? And so we talked about to our folks about the 50% rule. If you're having a good day and you think you can do things, do about half of what you think you can do, just because of your underlying fatigue, and think of just getting up and getting through the day as part of your job. That was helpful to our patients. Also, part of our job was to be advocates for the patients and help them explain the illness to their families, friends, people that were in their life, because many people didn't really understand the phenomenon. They couldn't understand the phenomenon. And I'll talk about it in a minute, but these are illnesses for most people. It's not really socially acceptable to vomit in front of people. So these were almost invisible diseases, right? For many of our folks, you couldn't see, you're not missing an arm or you don't break your arm and it heals. So these were, for a lot of family and friends, it was very difficult for them to conceptualize the illness. And then helping patients deal with the unpredictability of the illnesses. For a lot of our gastroparesis patients, there's a cyclical nature to the way the symptoms would come, and oftentimes there wouldn't be a very good pattern of what they could eat one day and what they couldn't eat the next day. And so people would develop almost a fear syndrome of, uh-oh, here it comes again. And so we worked a lot with that. Again, I think the psychiatric overlay is still prominent a little bit in some providers that don't understand these diseases. I wish that we had come a lot farther than we have about it, but part of the research that we've tried to do in the last 30 years is to try to talk about why that is. Again, these are often invisible kind of illnesses, somewhat cyclic. I know I've spoken a lot to this, or have spoken to the CVS group with pediatric kids, and that a lot of times you'll have kids that will go out on the weekend, they're having a good day, and they'll be playing, and then maybe 48 or 72 hours later they have an episode, and so other people begin to make judgments about, oh, well, he looked fine on Sunday, why is he missing school today? And one of the things that we now know about these illnesses is they really are driven by the autonomic nervous system, right? And that there's almost a 48 or a 72-hour lag period in terms of when you have a stressor or you overdo it. Usually that doesn't show up in about 3 hours or 6 hours, it'll show up maybe 48 hours or 72 hours. And so people, in their mind, they're trying to draw cause and effect. And I think that's part of why sometimes providers think negatively about some of our patients. As we mentioned before, we didn't have very many tools in terms of measurement early on. We had just perfected the gastric emptying test, and those don't necessarily even tell us a lot about people that have gastroparesis. There are many people that have gastroparetic type symptoms that do not have delayed emptying. And we're still a little bit limited in terms of our diagnostic abilities. For many of the patients that we worked with, we would do full thickness biopsies through J-tubes or through our gastric electrical stimulator, the Intera, the Pacer. We can now look at that and look at the muscle striata, but we didn't have those skills early on. That was silver stain biopsies that we were doing. So, and again, many providers were not familiar with these diseases, so they would kind of go down through their checklist of, okay, well, you're supposed to have this symptom and you didn't have anything on this test, and what do we do next? Or might they just tell folks, there's nothing going on with you, you've just got some anxiety going on or whatever. I think that was very traumatic. That could be very traumatic. And one of the things that the Gastroparesis Clinical Research Consortium has done is actually, again, kind of look at some of the etiologies of the different subtypes of gastroparesis. We know that there's diabetic gastroparesis. The most common is idiopathic gastroparesis. We don't really know the cause, but sometimes it will be secondary to a viral, like a GI virus, that just never completely resolves. And occasionally with a lot of our folks, it would become secondary to someone having an emotional trauma. I remember we had a lady that was in our group that we worked with that had been held up at gunpoint, and she'd not had any gastroparesis symptoms before that, right? So the providers are kind of saying, oh, yeah, you're just in shock from the trauma of being assaulted. And so we really had to work to undo that kind of mythology that kind of went on. And I think one of the things that Tom and I have been very convicted of through the years, and I think is really true, is that the trauma of the illness itself for many people, that fear of, here we go again, I'm going to get back into a vomiting cycle or whatever, causes very traumatic experience, is a very traumatic experience in and of itself. And that's one of the things we've constantly looked at in all of our health-related quality of life work that we've done and all the measurements that we've done through the years in terms of looking at depression and anxiety, that it's not causal, right? That it's secondary to the illness experience itself, or maybe even some well-meaning providers that often make things worse. And Tom is very good about describing that too. And that needs to be acknowledged, but it also doesn't need to be something that you get stuck in, right? And you don't want to build an adversarial relationship between people that make mistakes in terms of diagnoses, and everybody sitting around these tables have probably had some of those experiences. I was talking with Donna earlier about her son, and she's had a few. So it's really a delicate dance that you work toward a partnership as a team and not try to point fingers of blame toward well-meaning folks that just used their bag of tricks and somehow missed a diagnosis or didn't help people. But that's something that really needs to be named, and I think that's something that we offered a forum for doing within the support group. I think providers that have not had much experience with some of these illnesses have a lack of self-efficacy themselves. They kind of go through their toolbox, which is limited, and then they're like, I don't know what to do, and they feel some hopelessness, and they feel like they're not doing their job. And I think that one of the things that I really would like to study is people that, like Tom and other folks that work a lot with people with these types of illnesses that are time-consuming and intensive for the families and the patients and the providers, and how being in a space where you can help, and whether it's just doing a support group, is really very positive and can kind of help the provider not get burnt out themselves, because they get burnt out as well. And so I always go back to that partnering kind of phenomenon. So just a few things from the support group learning. We had a lot of people that would share things that were very unorthodox in terms of treatment. And we would never try to say, well, don't be doing that. We would just say, go back and talk to your primary care provider or your gastroenterologist about this. I remember we had one woman she would have a lot of distension and bloating after she'd eat. And she was a little old lady from up northwest Tennessee, and her husband would take a plunger to her back And she swore that that helped with bloating and distension. And we're like, well, just be careful, And she actually worked with Dr. Abel, so he knew all about this. And one of the things that we'd have a good laugh. I mean, this was something that was very good for these folks. And nowadays, we're on the internet. These were the pre-internet days, and that's why I applaud Oley Foundation that you get the support. But 30 years ago, our monthly support groups were really a way to actually get people in a room that could laugh about throwing up, to be able to laugh about nausea and vomiting and your belly bloating out like you're almost 6 months pregnant. This was something that was very useful for our folks in the groups. It really helped them, I think, to feel, to instill some hope for them and to help them feel kind of normalized, right? Because, like Sharon has shared, that a lot of these, especially if they were pioneers in the field like she was, there's not too many people you can have those discussions with that understand that phenomenon and what that was like for them. We did have a lot of mortality in our group, and looking at over the last 20 years, as we know that gastroparesis is usually associated with other organ system problems. We have a lot of folks with autoimmune problems. We have a lot of people with urinary problems, kidney problems. It goes along with fibromyalgia and lupus often. And so we had a lot of mortality in our group, and that unfortunately the support group became a place to actually process that. And with a review of smaller group of people that had gotten the PACER over the years, and these were people with really severe cases, they had about an 11.3% gross mortality over 20 years. And just to give you a baseline for that, anyone, just in terms of health systems, if you come into a tertiary health system, the general mortality rate's about 3%. So these were higher rates. So just to name that was important and have a platform for the families. And again, going back to building trust, I think the group believed that we were there for them every month. We were accessible to them in terms of being the providers. And in our support group, we would have a sort of an expert would come and talk lightly for about 15 minutes, and then we'd have a lot of Q&A. And the group was supposed to last about an hour, hour and a half, and we never got out of there. It was always, people would just hang out for about 2.5 hours. And so I always remember we'd have it Monday at 6 p.m., and some Mondays I'd just be tired, and I was like, oh, I don't want to do this. But again, I would find such energy from just being in a space where you could listen to people and help people in those groups. So patient and provider care teams, I think those partnerships are really critical. I lift up this lady here. Her name is Krista Lynn. Some of you may know her from other groups, but she works with the Institute for Healthcare Improvement's 100 Million Healthier Lives, and that's her special needs son there and her daughter. And she has drawn this care map of 45 different entities that she had to talk to actually coordinate her son's care. And many of you have probably experienced something similar to that. She found that she had to actually give up her day job to actually care for her son. And so I think it's just important to name that and to honor all of you that do that in your lives. And most of us can't afford not to work. But I like the way that she kind of describes how you've just got to have all hands on deck to do this work. I think I've already talked about most of these other things here already, but I think it's most important that providers truly listen to patients, because there's a concept that used to be called the wisdom of the organism. We all know our own bodies, and you want a provider that really listens to and incorporates that information into a care plan. I think that's really, really important. I think open communication and transparent sharing is really important, especially if you have to deal with difficult diseases that really impact your quality of life, because I think even a provider that can say, I don't know, is a very healing provider, right? Instead of just brushing you off or moving you on to another provider. And saying, I don't know, but we can figure this out together is a very healing phenomenon and healing process. And as I mentioned, I think those partnerships keep the providers that are doing this work from getting burnout too. So I think it's just good for everybody. So I'll just briefly talk about something in an article that we published last year. We've been working over the last 30 years to incorporate patient reporting into our data and into creating care plans for folks. As I mentioned before, health-related quality of life it can either be disease-specific, like specific to gastroparesis, and they've actually, through the clinical research consortium now, they actually have been using the Cardinal group. There's a Cardinal survey that they use to look at disease-specific health-related impact in terms of gastroparesis. Or it can be a global measure, and a global measure might be just asking you, how are you doing today on a scale of 1 to 5, poor to very well. Patient-reported outcomes are now, in the last decade, have become very important in terms of the NIH, and it's really, just to give you a working definition, it's the report of the status of the patient's health condition that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. Now in the NIH, they have that cataloged in what they call PROMIS, Patient-Reported Outcomes Measure Information System. They're not totally widely used, especially in primary care settings right now, and there is some question about how you incorporate that into data that the patients, what the patients share with the other quality of life measures and the other data that's being captured in terms of the phenomenon of their illness or their care plan, et cetera. So this is a very busy slide, which I won't go into too far, but again, going back to Tom Abel's love of acronyms, early on, and this is actually published in that article that came out in 2017, we looked at what was called total symptom score rating scale, and that was on a Likert scale, 1 to 4, 4 being the most negative impact of the symptoms of gastroparesis, the nausea and the vomiting, abdominal bloating, distension, being sated early, anorexia and or abdominal pain, with the higher scores showing more impairment. So ever since we started the very first trials that we did, and we actually did the early studies of cisapride, which you know is now not on the market anymore because of cardiac abnormalities with some interactions with other drugs too. We've been looking at total symptom scores that the patients have been sharing with us, and that's been driving the work that we've done. We started the support groups in 1990. Those went through 2002. And we had a lot of learning from that. And then we had developed what Tom called the ADAPTS. He called it a diagnostic and prognostic screening, which later morphed into the IDIOMS, Investigator-Derived Independent Outcome Measure. And we've been combining those measures, and that's a provider-rated measure, with the total symptom scores of the patients through the years to try to help develop that care plan and do a better job of delivering care. The IDIOMS looked at intensity of service. The IDIOMS also looked at services in terms of healthcare utilization, with how many, ED visits, outpatient visits, inpatient care, et cetera, were being used with a higher score indicating more usage. Other organ system involvement, and again, we know now, which we did not know then, this is not just a GI disease, this is a constellation of diseases that cut across many organ systems. And then intensity of the symptoms. And one of the things that we consistently have found is very face valid is the sicker people are, and the more duration of symptoms, the longer duration of symptoms, usually the more impact they have in terms of quality of life. And if they do have anxiety or depression, it's going to be secondary to that longer symptom duration time or more intense symptoms. So this article just sort of shares some of the group work that we have done over time with that. We found doing some psychometric studies, and that's just comparing different types of surveys, et cetera, that there was good convergent validity between the IDIOMS and the sickness impact profile, one of the early measurements that we looked at that was not a disease-specific, but a general quality of life measure, the psychological general well-being scale, and then many of you are familiar with the short form 36, which came out of RAND, and then they had the short form 12, now they've even got a short form 8, but it's just a generic kind of now what they call population management tool to look at larger populations in terms of how they're functioning secondary to any type of illness. One of the things that we've also found over time is that, again, as I mentioned, and this is actually, this Hessler study came out of the clinical consortium, the gastroparesis consortium as well, was that higher anxiety and depression scores didn't necessarily correlate highly with disease severity and longer symptom duration, but not gastric retention. So again, just a gastric delay in gastric emptying does not mean or does not necessarily correlate higher with those types of emotional symptoms, but the illness itself, that experience of illness probably over a longer period of time, or disease severity being higher, does correlate with higher emotional distress, which makes sense. And then we've looked at the beauty of the consortium is that we can look at larger scales of patients across those different sites, these 5 or 6 different academic medical centers. And that we found that the baseline idiom score, as well as high vomiting scores, remember that's the patient-related metric of kind of rating their own symptoms, was very significant of mortality in a long-term study that we're looking at. There are many other indicators that we're just at the beginning of looking at. Inflammation is really another area that is a huge area they're about to publish in, but that's, for most of us, we know that that's really highly correlated with severe diseases and exacerbates any type of a disease phenomenon. So our ultimate aim is really to dispel the notion that there's some psychiatric underlying cause, and I wish I could say that there's that went away 15 years ago. It hasn't totally gone away, but we're going to keep doing that work out in the field. And I would invite you all to come to a breakout this afternoon, and it'll be a treat not because of me, but because I actually have a former patient who's going to join me. She was actually one of the early folks that came to our gastroparesis support group. She actually went through some of the biofeedback work that we did. We actually worked with some people out of NASA to use some of the techniques that they use for biofeedback for astronauts. You know, because when you go up in outer space and you have zero gravity, you get terrible nausea and vomiting when you come back to this trajectory. And so we actually adapted a lot of their biofeedback techniques, and we found that it was very useful for people with mild to moderate gastroparesis. And so she graduated from therapy. She went on and got a master's in integrative care in San Francisco, and she's a yoga instructor now, and she's going to present with me this afternoon about kind of continuing this theme of the partnership, and she'll also have some ideas from her own personal journey in terms of how she's coped with alternative therapies and how that's been useful to her. So I'd invite you to come and join us this afternoon. Okay, so I'm done a little bit early, but I don't think anybody minds. And I know you guys have been very patient all morning and probably need a break. So I don't know if there's any questions, or we can wait till this afternoon.
Okay, that was wonderful. Teresa, I love this opportunity. I get to ask the first question, or it's a comment combined with a question. I know there are 5 centers in the U.S. that have a strong focus on gastroparesis, but because you opened the door to Dr. Abel's hair changing color, I truly worry what's going to happen when the Tom Abels of the world decide I'm finished, and they have every right to retire as the rest of us do.
That's a good question. That's a great question.
What's the answer, Teresa?
That's $1 million question. Well, you know, I think actually Tom has always been such a spectacular mentor to young residents that work in this area that I think he's got a whole, I know he has probably about 12 young people that are now scattered all across the country that are physicians that now work in this area. And they would not have come into this work had it not been for his mentoring or him bringing into that. I mean, the other thing is that I think for many providers, understanding the baseline phenomena of these illnesses is really important. I remember when I used to teach gastroenterology residents about the illnesses or the experience of the illness, I would say, okay, now think about that last GI bug you had where you're vomiting constantly for 2 days and you're on the couch, and how tired you felt and how sick you felt. Now multiply that by 20 in terms of intensity, and I want you to also think about it never going away. It may cycle in, it may cycle out, but it just never goes away, because many of the providers just don't have a baseline for understanding that phenomenon. And one of the things that Tom has always been so fantastic about is actually trying to get all of the folks that train under him to understand that. For example, he won't let, and this was not common practice 30 years ago, it may be common practice in most medical centers now, you can't do a procedure on someone unless you've had it done yourself. So in terms of scoping and stuff like that, so I'm like, wow, he's a great teacher and a mentor that way, because you can't, you can't really understand that unless you've been through it. Now people don't have to have full thickness biopsies if, you don't have to do that to do one, but to the extent that it's a procedure that can be something that the trainee can go through, it's not just see one, do one, teach one, it is actually go through one and then do one, train other folks and be part of that experience. So I think Tom's got a stable of folks that are going to carry on. And by the way, he is no longer working on Wednesdays, he told me, because he hit a milestone birthday. I'm not going to say which one that is. Recently. Yeah, he's 70 now. So.
Okay.
Have you done any work on small bowel dysmotility? Because from our point of view of this type of treatment, gastric is more of a tube feeding thing. Small bowel is more of a parenteral nutrition thing.
Through the years, I worked with some folks that did have short bowel, but we focused more on the gastroparesis. Small bowel dysmotility. No. I mean, this is really more on just the gastroparesis side. Yeah. So.
Bob. Whoops. Raise your hand high. There we go. Come on, Bob.
I'm a caregiver. My husband has diabetic gastroparesis. And in the last 4 years, we've been through 5 doctors. And we ask for coordination. The article that Dr. Abel wrote was so true. To get them, first of all, to believe, and second of all, to coordinate has been incredibly frustrating. And the first time when you go to a new doctor, they take a look at my husband because he's looks like he's out of the concentration camps. And they go, we're looking for cancer. And it's so frustrating and it's wearing on him, and I'm afraid he's going to give up.
I have great empathy for you and your husband, and I would just say it's probably going to be incumbent upon you as the caregiver to wait until you find somebody like Dr. Abel that can be sort of the ringleader of that team. For example, he doesn't treat pain management. He also has a pain management specialist that's part of the team, but picking the right person and provider for that is also important in terms of how you put your team together. So don't give up, and if you haven't already reached out to him or to myself, and I don't know where you're based, but we can probably direct you towards some folks that at least have an understanding of the illness. So.
Hi, I'm Mary.
Hi.
My 10-year-old daughter was born with gastroparesis and visceral hyperalgesia. She does have a G-tube. She's on numerous pain medications and Raglan. I've recently learned about vagus nerve support supplements, and I was wondering how you feel about those and what your take is.
I cannot answer that. I'm sorry. I'm not up on the field. There's probably folks around this table that probably could. What we do know, though, is that there's certainly a vagal innervation issue with gastroparesis. And in the early days, we didn't really look at autonomics like we did now. But through the studies that we've done, particularly for folks that have the diabetic kind, there's more vagal innervation issues. So I'm sorry. I wish I could answer that.
Is that it?
I've got one more.
One more question. So I happen to have the unique opportunity to be a provider as well as a caregiver. And I live with somebody who has gastroparesis, and this person is not my family member, but I've come across a situation. This person does not have the support of family. And I've actually come across this with patients of mine as well, that their family just don't believe them and the symptoms and just the journey that they're going through. Is there a book, articles, something? I just saw the article that the doctor wrote that might be helpful. Is there anything else that you could point people to kind of educate themselves, or possibly give to families to see?
I'd say that the support group article that we just published last year has some of that information in it, not to the detail that probably would be useful, but I would say that one of the things that was a real platform for our support group was helping family members that, again, looked at persons and thought, well, this is sort of invisible illness. This is not a real phenomenon. Or why can you eat a greasy hamburger today and then 2 days later you're sick, or that sort of thing. As human beings, we seek cause and effect, right? We want to make sense of what we see. And so I think family members sometimes in the early days, particularly with our folks, would say, oh, he's not really sick, right? And then there'd be a case where they might throw an embolism and die. And it's like, well, I guess he was sick, and that was really sad. But I think groups like Oley Foundation, and it's very important for them to educate the families and have venues like support groups, whether it's on online chat or whatever's available. The virtual support groups now are so different than what we used to have. But the other thing is just actually having the family members talk with someone else who's been through it, or their family members that maybe were a little disbelieving at the beginning and then they were convicted of what's actually going on, and the journey that person and their family's taken might be useful. So,
thank you.
Yeah, I'm sure there's people in this room that could tell their story that would be phenomenal. Yeah.
Anyone interested in commenting or offering some help? Mary, microphone.
I was one of the fortunate people to see Dr. Abel. They had given me a year, and one of the doctors in Gainesville, knew of Dr. Abel and told us about him. Well, I had a niece who lived in Little Rock at the time. She got on the phone to call the department, and he answered the phone. And within 5 minutes of her hanging up, he called me in the hospital in Gainesville.
Wow.
We went to see him. Oh, my husband was a teacher, so we had to wait till spring break, and this was January. But we went to see him. He agreed that the stimulator would be something that might help me. So we went back to him in the summertime, and he put in a temporary one through my G-tube. And I carried the stimulator in my pocket. Within 24 hours.
You converted nicely, huh?
I said, I don't want to give this back.
You didn't want to turn off the temp so that you could put in the permanent, right? Yeah, because it worked so well. Great.
So I have referred tons of people to Dr. Abel. Just, give him a call, try.
And some people literally have followed him. He went to UT, then he went over to Arkansas, and now he's in Kentucky. Well, Mississippi and then Kentucky. I think he's going to stick there for a while. He's in Louisville now, and a lot of people just follow him like he's the Pied Piper for good reason. You've just described it. But to get back to this lady's question, I mean, really, this group would be very well positioned to write your own book about the experience so that other people that are going through it can quickly educate their family and friends about what's going on. And some providers still, too. Yeah, actually. So thank you for sharing that. Yeah.
I'm going to add to that a little bit because you talked about support groups. When we went to Little Rock to see him and deal with the possible putting in of a stimulator, one of the people from the support group, it was Gems of Arkansas, came to the hospital, came to his office area in the hospital and talked with us about it. So it was somebody from a support group that came and described experiences as he had. So that was extremely extremely helpful.
So
to
someone
have
who's been through that
else.
experience has a great credibility, right? Because they know
Yeah.
whereof they speak. So yeah, that's a great point, Bob.
And this was before the fact, not after the fact, which was really, really nice.
Well, and that's what I've always appreciated about Dr. Abel. He's very proactive, right? He wants to get on top of things, right? So
Covered all the bases.
But anybody else? But anyway, I will be at a breakout, and I thank you for sticking with me. I know it's been a long morning, and I appreciate being back here. And good luck to you all. You're the heroes today.
Okay, we have a few minutes. We begin our corporate partner award ceremony at 11:45, and I'll give you a little preview. We have a laundry list of companies who support us. Some have been on this list for years and years and years, as long as I can remember. My memory's going, but still, I can remember this. And we hope you hang in there with us for this ceremony. Following the ceremony, we go directly to our exhibit hall with a nice lunch, and then afternoon breakout sessions. And I encourage you, if you're here with a friend or partner, caregiver, whoever, split up, attend as many sessions as you can. Live, learn, and make use of the information. I know last night was our award ceremony. We gave out all of our awards. But this morning, I have a special, very special award to present. It's a surprise. It's a surprise. So if I could have someone escort Dr. Kelly up here, I'd appreciate it. And if it were Bob Smithers, our president, be my guest. This award, and as she's making her way up here, this award is the Oley Foundation's 2018 Most Valuable Player Award. And it's inspired in memory of founding trustee Don Young, whose love of baseball, particularly the Red Sox, and Don, I won't hold that against you, inspired in him great respect for teamwork in sports, healthcare, and community. We present this very special, unique award to Dr. Kelly for serving us in so many capacities, and presently as medicine and science advisor, bringing her expertise to the European guidelines, ESPN guidelines, and beyond. We have a medical question. We're challenging some information that flows through our office. She gives it an okay or thumbs down, but she's always encouraged this partnership between clinicians, caregivers, members of industry, home care providers, in all capacities. So Darlene, we couldn't be more pleased, honestly.
Well, thank you, Joan.
And you keep us safe. You keep us
try.
as safe and spot on as we can be.
This has nothing to do with my ability to bat or throw balls or anything else on any sports field. Sorry about that.
I thought you were still on a softball team, no?
No. It's been a real pleasure to work with Oley. It was about a month before I retired, and I had a long chat with Joan. I don't even remember what it was all about the night before, and then I realized she was an hour ahead of my time zone. And it was getting to be toward midnight at my time zone, so it was toward 1 o'clock on Joan's. And I thought, oh, I better hang up. Well, my pager went off as I was walking into work, and it was Joan. Said, Darlene, I couldn't sleep last night because I think you should join our staff when you retire. And I was thrilled. I really wasn't quite sure what I was going to do, but the opportunities that I've gotten over the years largely because of Oley, have been great. It was a pleasure to be working with the Europeans, the real experts in many of the parenteral and enteral nutrition products and treatments. I learned so much from them, and so you also get me to many meetings.
That's right.
And
that's
you
right.
keep my memberships up. So it's been an amazing trek afterwards. So thanks so much. And I've got to frame this somewhere.
Yes.
But
you
it won't
do.
have a baseball or a bat anywhere near it.
Do you want to
So-
mention Dr. Mundi just moved in and he's going to
Oh, yes. Just walking into the room was my good friend Manpreet Mundi. Manpreet how long have you been at Mayo, Manpreet? Okay, he's been on the faculty at Mayo 10 years. He's an endocrinologist, and he's really taken on a lot of the patients who I've known over the years. It's hard to leave a job when you have all these patients, but we've had some terrific people to take over. So I was originally asked by Andre van Goosem from Belgium if I would join this home artificial nutrition work group. And it was while I was still at Mayo, and so I had access to a lot of data, which was very nice. But after you leave Mayo, after you've been 1 year out, if you don't have active protocols going, you don't get into the data anymore, which was one of the things that it was all de-identified data. So those who were part of my practice were not identifiable at all from the data. But I thought that it was probably they could do better if they had somebody who was still actively working at Mayo, and also with Oley. And Dr. Mundi is part of the board of directors of the Oley Foundation. So it was easy to, and the people at Hand Group said, oh, you at Oley can decide who's going to follow you up. There had never been anyone from the US on this committee before me, so after about 14 years, I'm kind of retiring from that group too, and I'm totally delighted to have Manpreet follow me up. I was really afraid he was going to say, no, I can't do that. So I was happy that he did say yes. So he will be representing you all on the home artificial nutrition group. And although doing the clinical guidelines was an excellent experience, once was enough. We spent 3 years on this, back and forth to Europe, so that wasn't too bad. But anyway, Manpreet, we welcome you to this group. So, thank you all.
We certainly do. Thank you,
Come
darling.
up here. You should come up here. So this is the guy I was talking about. So anyway.
Thank you. No, thank you.
Thrilled to have you in this part of extension of Oley data across the ocean.
Yes. No, it's a great honor, and Dr. Kelly's been a great mentor, so I really appreciate everything both Oley and Dr. Kelly have done for me. So thank you.
Thank you.
Yeah.
Thank you. Thank you both. Thank you. Let's get on with our very important corporate partner program, and Rosalind Dahl, Development Director, as I introduced her last night. If you see Roz approach you, you have two options: pull out your wallet or run.
Good morning. I'm Rosalind Dahl, and as Joan said, I'm the Development Director. I'm also Communications Director at Oley Foundation. So if you have comments about some of the patient education materials, you can talk to me about that too. And I promise I won't ask you for money in person. I would like to ask the Oley board members and advisors to come forward and be on this side of the stage. It's the left. So you're going to greet partners as they come forward. We are very grateful to our friends in industry Without their support, we could not hold this meeting or offer Oley's many life-changing programs. We are especially thankful for our corporate partners who support the Oley programs all year round. Partners exhibits are indicated by gold star balloons, so you can't miss them in the exhibit hall. A complete listing of partners is on page 15 in your program. As a token of our appreciation, we'd like to recognize these partners this morning. We'll be calling up partners to receive their awards by donation level. We ask that you hold your applause until all partners in that particular level come forward. Partners, as you were called forward, please shake the hands of the board members so that they can say thank you to you, and come up on this side of the stage and then remain on this side of the stage so that Swapna, who was speaking just a few moments ago, can say thank you to you as well from the patient perspective. So our first level of partners, oh, Justin, is it possible to, oh, they've got it, okay. The first level of partners are our patron level partners, and these partners donate between $5,000 and $9,999 each year. Applied Medical Technology, if you could come forward, please. Yeah, she's coming. Apria Healthcare. Cook Medical. Functional Formularies. And Soleo Health. Thank you very much, patron partners. Thanks for being flexible this morning, too. Thank you, Danielle. Okay. Our next level of partners is the benefactor level, and these partners provide $10,000 to $19,000 worth of gifts to Oley during this year. We call to the front BioScript Incorporated, Briova RX Infusion Company, and I'd like to give a special shout out to Briova this year for increasing their donation. Nestle Health Science and Real Food Blends. Thank you for the benefactors. Thank you, Allison. Thanks, Chris. Thanks for calling. The next level of partners are our Bronze Star partners. And these people donate between $20,000 and $29,000 each year. We are pleased to welcome Baxter International Incorporated, Cardinal Health Incorporated, Fresenius Kabi USA, Halyard Health, and Option Care. And again, a special shout out for Option Care, who increased their donation this year as well. Thank you very much. Thank you, Lisa.
They come out of order.
Thank you so much. Whoops. Thank you very much. Right here. Thank you. Thank you, sorry. Thank you. Thank you so much. Thank you. Thank you. Our next level of partners are our Silver Circle partners. Both of these companies have been supporting us for many, many years. And we'd like to say a special warm welcome to Coram CVS Specialty Infusion Services and NutriShare Incorporated. And I forgot to mention that they provide between $30,000 and $49,000 worth of support during the year. Our next level partners are the Gold Medallion partners, and this would be ThriveRx, who donates $50,000, between $50,000 and $69,000 this year to help support Oley programs. Thank you so much. And new this year, we have our very first titanium level partner, Shire Incorporated. Shire has donated $150,000 this year, which goes without saying. It's a tremendous, tremendous contribution. We're very pleased to have their support to help make this meeting and other programs throughout the year free of charge. It covers a lot for Oley and for you for the services. So please say thank you to everyone in the exhibit hall this morning. You're welcome. So are all three of you going to talk? Okay. Okay. So I'm welcoming the team here, Karen Ruth, Michael Ferguson, and Kristen Bissett. And Karen Ruth, I'm going to turn this over to you to say a few words.
Yeah, thank you. A great kickoff session this morning. As with all of the sponsors, we are honored to be a part of your community and sponsor the conference this year. You know, every year I go home in awe of your courage, your resilience, and your positivity. I also admire your desire to learn, share, and connect, as well as your commitment to advocating for access to care and also to continue to support research to advance science. Your conference is 33 years strong, and that deserves a round of applause. As you know, Shire is a leader in biotech in rare disease and specialty conditions, and we have supported the GI community for over 10 years. Our commitment is to continue to invest in R&D to bring new and innovative therapies to the GI community. I'd like to also thank the Shire team who is here with us in Memphis today, and I hope you all have the opportunity to talk with them during the exhibit hall and lunch today. But I'd also like to introduce Mike Ferguson, who is the head of our GI team back in Boston, and Kristen Bissett, who is our consumer lead for the GI team. Both Kristen and Mark are fearless GI warriors. They've been with Shire for over 10 years in the GI teams, supporting various different clinical programs, and we're proud to be here today. Kristen would like to share a few words with you.
Thanks, Karen. I had to take my opportunity to hijack the mic to thank you guys personally. I was introduced to Oley last year, so it's been one short year that I've worked with this organization, but I'm so blown away and grateful for the opportunity, the education and support you've given me in my role to learn and embrace the communities that we treat. So nothing that we do goes without the support and knowledge that you guys offer us. I remember sitting at a lunch table last year and I said to Joan, wow, people share things here and it's so awesome, like everything. And we've taken a lot of that feedback and those conversations and insights and emotions and care for each other as members of the community, as caregivers, as patients, as care team members, to bring that to light in our work. So we're excited to continue to remain committed to producing programs and resources that support you and your family members and your healthcare providers so that you can be educated and advocate and be educated and empowered to advocate for yourselves and really get what you need out of your treatment journey. So thank you for having us. It's truly always a pleasure. As Joan would say, I feel very grateful to be a part of this family. That's what she calls you all the time, so I feel very lucky. Thanks, Joan.
Thank you so much.
Thanks, everybody.
Thank you so much. I just, stay where you are. Beyond the financial support given to Oley, which is so important because we're committed to keeping programs free, including this conference, to attendees. I want to thank you, each and every one of you, for responding positively when you're invited or a special request comes along. Can you speak at this Oley meeting? Can you speak at a regional meeting? Do you have any thoughts on this reimbursement mechanism? It is with your professional support and guidance that we're able to do what we do. And we get a lot of credit for the things that you do and you contribute to. So it's a heartfelt thank you from all of staff and all of the trustees. So thank you. And now, stay where you are. We have Swapna here to offer her perspective on your support for the Oley Foundation.
Thank you. You won't remain standing for too much longer. So on behalf of the patient and caregiver community, those that are especially here today, those that are watching live, those unfortunately could not make it, and the many that have not found out about Oley yet, I want to say simply thank you. It is with your support that we have resources that we would not have had otherwise. I was born with short bowel syndrome 28 years ago. I've been fed with TPN for 28 years and enteral nutrition for 20 years, and 4 years ago I had a small intestine organ transplant. But in this journey, unfortunately, I did not find out about the Oley Foundation until 6 years ago. My pharmacist from my home health care provider actually asked us to go to a home TPN day conference in Nashville at Vanderbilt, actually led by Dr. Seidner's team, where Oley presented, and I found out about the Oley Foundation. And in 2016, just 2 years ago, my health was stable enough where I got to attend my first conference, and my life changed, transformed for the better. For the first time in my life, in my mid-20s, I saw young adult females walking around with backpacks with TPN tubing coming out of it, or little kids running around with G-tubes hanging out under their shirt. But most importantly, they were living their life to the fullest and not letting their diagnosis define them. They were needing to go back to their room to take a rest, or many said, oh, I have to go back upstairs, I have to get fed or get reconnected, or the next morning they would come an hour late to the main session because we were tired. And it was okay, that was our normal. I went back home with a new purpose, a new attitude. I became a full force advocate. I became an Oley ambassador, and I started giving talks to my home healthcare provider, my hospitals, about the content I learned here, about scrubbing the hub for 15 seconds, and more. And I got to learn about the diversity of the industry, the vendors, the products in the community. I'm actually jealous of kids who do have central lines and G-tubes today. They're very cool. I got to see backpacks that I wanted. My backpack was conveniently lost on the plane on the way home. Thanks, Southwest. That's a true story. And now Joy and I have matching backpacks. Or I got my set of knives Japanese knives from the silent auction that I still use today. And I got to learn from a dietitian how to track my I's and O's on an app. It's not the 90s anymore. And it just transformed of how we were to live our life with this disease, with this diagnosis. Again, thank you for providing this avenue for resources that, again, we would not have had otherwise. It took us 20 plus years, and I'm proud to introduce my parents to their first Oley conference, and I know they're seeing resources. They wish they had, and Farah is not here, but Layla, a little girl, I'm sure you guys will all meet, is the cutest. She lives down the street from me in Alabama, of all places, with the exact same diagnosis to the etiology, but born 22 years later, is 6 years old. And this is their first Oley conference, because Layla's asking, why do I have a line? Why do I look different? And I said, come, come. Because of your support, we can have stories like this. Thank you.
So thank you again for all you do for Oley and for the patients and the members. We'll see you all in the exhibit hall in just a few minutes. Thank you.